Good afternoon, everybody. Welcome to the sunny state of Florida, Orlando, and the American Academy of Ophthalmology meeting. We're all looking forward to learning from each other and hearing about all of the amazing progress that we're making in the world of eye care. And nothing is more exciting and more riveting than what's happening in the revolution of retinal diseases. Welcome to INNOVATE Retina. This is a program that was born out of our department at Stanford University and has now gained momentum where we now have friends from all over the world who are not only leading in their own practices, but also leading the way to the future for our patients with new therapeutics and new devices and new techniques and new insights on how we take care of patients. This INNOVATE meeting has been put together by the team at iVista as well, who have been instrumental in the program. I just wanted to run through some housekeeping slides, if we can advance. So I'm the good-looking guy in the middle, but the even better-looking ones are Diana Do, Quan Nguyen, and Stephen Smith, who have been the brain trust behind this meeting, not only with the work that they do and their contributions, but also in rallying amazing speakers and support for the meeting. If we can advance. So none of this happens without really an all-universe stellar crew of speakers that have come from many countries, some that represent the finest in clinical practice and in surgery, but also our colleagues in industry that are really pushing boundaries in how we can deliver the best care to our patients. So we are indebted to the faculty and to the speakers that are here today, because none of this would happen without their expertise. We have several sessions. There's plenty of coffee and snacks in the back. Please stay till the end where we have some special surprises that are happening this evening. We have dinner around 6:15 and then a really unique non-CME panel that brings together leaders from industry and academia to kind of talk about the future of the field and where we might see ourselves tomorrow, next year, and into the future as well. And we plan to have these meetings again yearly, so if you have to leave early today, we'll see you next year. Learning objectives, so many things to learn. You can read them right on the screen here for me. And then this would not happen without the work of our activity providership from the CME credit and the incredible work of the iVista team. Next slide. We are indebted to our sponsors. We have an incredible group of sponsors that have come together because of their interest in letting all of us learn about their technologies, but also because I think they truly care about the future of our patients and how we can work together as a community to advance care. So all of these sponsors we are grateful to, and we'll recognize them as the afternoon goes along. We have evaluation and test credit, so if you want to take a quick picture, but this information is available for you as well. We're happy to provide any assistance that you may need, and we love your feedback for the future. So thank you for joining us. I will ask speakers in the subsequent sessions to come and join us up on stage, and we'll start with our first session, and I'll send it over to our two moderators, Dr. Diana Do and Christina Wang. Thank you.
Thank you. Thank you. Today I have the pleasure of starting the neovascular diseases section with my good friend, Dr. Christina Wang. Christina, how are you doing today?
I'm doing great. It's great to be back at INNOVATE. Thank you to you, Quan, and Stephen, and Prithvi for putting together this highlight of AAO.
Great. We do invite all the speakers to come up to the stage now to join us. And I'll start off with introducing my colleague, Dr. Ted Lang, who will give us an update on the real-world use of faricimab. Thanks, Ted.
Thank you so much for the invitation 45 minutes ago to give this talk. I am not Durga Borkar, but I will do my best. Let's see, I don't have slides to look at here. Interesting. Okay. Here are my disclosures. Today we're going to hear some really great talks about therapeutic agents that are currently in the clinical trial setting. But once a drug comes to market, there are various considerations when you're trying to evaluate the safety and efficacy of these therapies outside of the clinical trial setting. And this will actually represent the more heterogeneous population with differences in access to anti-VEGF medications, as well as differences in physician treating decisions. Oftentimes, physicians can't or choose not to replicate the standardized treatment protocols that we use in our registered trials. And so looking at real-world data allows us to provide a critical dimension when we're trying to evaluate the safety and efficacy of these new agents in our armamentarium. Also, there's oftentimes more data out there than in the typical 1 to 2 year time span of a registered trial. So the FAR Retina project is a retrospective real-world study leveraging data from the IRIS registry. All the patients in the registry either had a documented diagnosis of DME or neovascular AMD, and at least one faricimab injection from February 2022 to March of 2023. They had to have at least 12 months of pre-index data, as well as 12 months of follow-up data with the appropriate visual acuity and CST anatomic measurements included. So you can see here, this is for the neovascular AMD cohort. Based on demographics, you have about 201,000 patients that got any injection, and it whittled down to about 5,736 patients of 6,808 eyes in the 24 months cohort. You can see here a majority were previously treated, 94%, and 66% of those eyes switched from aflibercept 2 milligrams. Looking at the visual acuity data, you can see that there was maintenance of vision through the 2 years of treatment, both in treatment naive and in the previously treated eyes. Interesting point here is that over half of the eyes had 20/40 or better vision at baseline, both for both the treatment naive and the previously treated eyes, which I think speaks to the confidence that physicians in the United States have on using this agent in this population. If we look at the anatomic outcomes, the CST also improved through 2 years of treatment, both in treatment naive as well as in the previously treated eyes. Again, of note here, the CST numbers were lower at baseline in this real-world data study compared to the Tenaya and Lucerne studies, which had 356 microns at baseline. We hear about 300 or slightly under 300 microns at baseline. So these eyes weren't nearly as swollen at initiation of faricimab treatment as the eyes that were enrolled in those phase 3 trials. As far as the number of injections, the first year had about 4.5 injections in the first 6 months, and then it went down to about 2.5 in the second half of the year. So you can see a reduction of therapy in both the treatment naive as well as the previously treated eyes. Looking at the DME cohort now, we had about 1,254 eyes of 953 patients. Again, a majority were previously treated, not as much as the neovascular AMD eyes, so we had 87% previously treated eyes here, and 73% of those switched from aflibercept 2 milligrams. Visual acuity improved in treatment naive eyes and was maintained in the previously treated eyes, again speaking to the maintenance of efficacy once you do switch the therapy. Anatomically, the CST also improved through the 2 years of faricimab treatment. Again, as in the neovascular AMD group, there was thinner retinas on switching or treating of treatment naive eyes than there were in the Yosemite and Orion clinical trials. Just like in neovascular AMD, we also saw about 4 injections in the first 6 months, and then it went down to about 2 injections in the second 6 months, which was maintained through 2 years. As far as adverse events, the rates of both endophthalmitis and intraocular inflammation were very low and consistent with what we saw in the phase 3 trials. Well, we'll switch gears here and look at 2 other real-world studies. The Truckee study was a 3.5-year study of neovascular AMD, and they also showed significant visual acuity gains in treatment-naive patients of about 5 letters or 1 line. The treatment interval extended also from 48 days to 60 days, and CST reductions were also seen in that trial. They had a complementary study called Tahoe, 2.5 years of follow-up in DME-treated eyes with very similar results, some visual acuity gains as well as reduction in CST. So in conclusion, multiple real-world studies have evaluated faricimab in use after 2 to 3 years, including the FAR Retina, the Truckee, and the Tahoe studies. And we have improvement in visual acuity in treatment-naive eyes, as well as previously treated eyes, with corresponding anatomic improvements. And these studies highlight the increased durability and decreased treatment burden, including previously treated eyes. Thank you so much for allowing me to speak today. Thank you.
Great job, Ted. I think we're going to hold questions to the end. So let us now introduce Dr. Jennifer Lim. I don't think it matters, Jenny. Yeah, thank you. Who's going to talk about dual mechanism versus high-dose anti-VEGF treatment for wet macular degeneration treatment trends and real-world outcomes. Thanks, Jenny.
Thanks so much, Christina. It's a pleasure to be here today and speak about dual mechanism versus high-dose anti-VEGF for neovascular AMD, for which I have the following financial disclosures, the relevant ones of which are in bold. Basically, when we're talking about dual mechanism versus high dose, we're really talking about faricimab 6 milligrams versus aflibercept 8 milligrams. And we now recently know through the Avenel extension study from the Tenai and Lucerne studies that in year 4, we maintain the dosing intervals that were seen in the original pivotal trials, and we still maintain the non-inferior best-corrected visual acuity outcomes as well as the CST reductions. From the aflibercept 8 milligrams, we know from the PULSAR extension study that we now have 3-year data that extends the data from the PULSAR original pivotal trial, again showing maintained dosing intervals with maintenance of the BCVA improvements and the CST reductions. Both groups have recently looked at PED subgroups, and both have shown that serous fluid resolution is better with faricimab 6 milligrams or aflibercept 8 milligrams in comparison to aflibercept 2 milligrams. And both did not show any new safety signals with these outcome studies. The PATS survey recently asked, what is your preferred first line of anti-VEGF treatment for wet AMD if there were no payer restrictions? So this is interesting. You can see here that 30.9% still would pick faricimab, and 29.7% would still pick aflibercept 2 milligrams, and only 8.7% would pick aflibercept 8 milligrams. You also see that bevacizumab is still coming in strong at 26.4. And again, this is your preferred first line without concern about payer access. So why is this? Well, we know that faricimab was approved in January of 2022 and aflibercept 8 milligrams in August of 2023. So this may be related to the slower uptake of this newer medication, and this may change over time. We've just heard a great talk about the real-world outcomes from Dr. Lang with regards to faricimab, so I'll concentrate on real-world outcomes with regards to 8 milligrams of aflibercept. There has not been as robust data because there are not these big trials that are looking at this. So Dr. Ali has looked at the IRIS database and the Vestrum database and looked at treatment-naive eyes to get these real-world outcomes. And in IRIS and Vestrum, with a median follow-up of 3 months and 4 months, we see that essentially the visual acuity outcome is dependent upon the entry of the visual acuity at baseline. That is, if the visual acuity was 20/50 or worse, on average, patients gained about a line of vision, about 5 letters. And in fact, 44% gained at least 5 letters or more. If the visual acuity was better than 20/50, essentially the visual acuity was stable, and about 20 to 22% gained about 5 letters or more through the 3 to 4 months follow-up. In terms of the dosing interval, you can see that initially patients are dosed monthly, and by the end of the 3 to 4 month median follow-up, the dosing interval was indeed increased to 63 days, or about 2 months. There's been another study, however, that has looked specifically to see after you dose a patient for 3 doses of aflibercept 8 milligrams, what % can then be moved on to at least 8-week intervals. And in this study by Bala, they showed that actually 46.6% still required dosing of aflibercept 8 milligrams at less than Q8 weeks. And this is in contrast to what was seen in the PULSAR study. Predominantly, however, these were previously treated eyes, so presumably these were harder to treat eyes. If you look at the treatment interval, you see that there was an increase of about 2 weeks with the switch to aflibercept 8 milligrams. In terms of prior treated eyes from the IRIS and Vestrum databases, the vast majority were switched over from aflibercept 2 milligrams to aflibercept 8 milligrams. The mean dosing interval increase was anywhere from about 2 to 3 weeks that was gained. And this gain in the mean dosing interval was dependent upon what they were on prior to the switch. So if the patient was on Q 4 to 6 weeks before the switch, after the switch, they gained about 2.5 weeks or 19 to 21 days more in terms of dosing spacing. If they were on Q6 to 8 weeks, they gained on average about 14 days or 2 more weeks of spacing. In the last few minutes here, I'd like to go into IOI with regards to aflibercept 8 milligrams. The incidence of sterile in IOI was studied in Germany. And in Germany, patients have to be examined 4 days after the injection. And because they were looking at patients more closely, they saw an IOI of 3.7%. And these were sterile, non-infectious signs of inflammation with complete resolution with anti-inflammatory agents. There has been a series in Japan that has showed a slightly higher rate of IOI, in fact, up to 8.6%, with some mild retinal vasculitis, again, responding very well to topical steroids. There was one case, however, that did have retinal vasculitis with a vein inclusion that did have a drop in visual acuity. And so there's some concern that perhaps in this subgroup of the population, that perhaps there is a higher rate of IOI in the Japanese patients. And I'd just like to show you here the IOI with regards to faricimab from the IRIS databases and from the Truckee databases. And we see here that the IOI rates are low at 0.13 to about 0.12%, and in Truckee it was 0.08% per patient with the IOI. Now, we all know, however, that we've seen retinal occlusive vasculitis reported, and it's felt that this rate is about 0.06 cases per 10,000 injections with faricimab, again, seen in the real world, but not seen in the clinical trials. So in summary, faricimab 6 milligrams or dual mechanism, and aflibercept 8 milligrams or high-dose anti-VEGF, both can give us extended dosing intervals with maintenance of visual acuity improvements and reductions in CST. However, the safety outcomes do show some IOI, some of which is not reported and did not come out in the pivotal trials, but are coming out in the real-world studies. Thanks for your attention.
Thank you for that wonderful update, Jenny. Now it's my pleasure to introduce Dr. David Brown, the one and only, who will give us an update on tyrosine kinase inhibitors.
Thanks very much. I've been working on this talk for weeks. I just found out about it yesterday. Anyway, I'm here to talk about TKI blockade, and we've been doing TKI work for a long time. These are my disclosures. This slide's actually from Peter Kaiser 2017. And at that point, we had all these TKIs, and all those have bit the dust, and we're still left with ocular therapeutics. And I'm going to add another one. I'm only going to talk about those two because they're the ones in phase 3 trials. So vorolanib is a potent anti-VEGF inhibitor and anti-inflammatory inhibitor. In other words, it's a TKI that blocks more than just VEGF. Here you see it blocks the JAK pathway. They promote that as really being important, especially for vein occlusion and for diabetes and inflammatory disorders. The competitor doesn't have it, and they say it's a bad thing. It can cause more inflammation. So they're both sustained release devices. The Durasert came from the same company that made Utiq and all of those, but now it's in a bioerodible. The other ones, remember, were plastic tubes that stayed in your eye the rest of your life. And it does erode over time in zero-order kinetics. In theory, this should give us better control with less seesaw. Both products I'm talking about have the same zero-order kinetics. I'm going to talk about what trials are out there that shows you what they did before the big clinical trials. This is the biggest trial of any of them, DAVIO 2. It's a phase 2 for diabetes. They had 50 patients in each arm, and they compared to aflibercept Q8. The retreatment criteria was not what I do in the clinic. You had to lose vision, you had to have fluid, but that being said, let's see what it shows. Here you have visual acuity non-inferior to aflibercept Q8. Same thing with the OCT. If you look at needing treatment, and again, there's treatment that you had to have a lot of fluid and vision loss to get treatment, but it looks pretty good, although most patients at the end of the day, 83% needed a retreatment before week 32. So it's certainly not lasting forever in everybody. Confidence intervals show you it's non-inferior, and with this, they were able to move forward. I'm going to show you the diabetes results from these guys, vorolanib implant. 21 patients, again, small numbers, single dose, but it looks like an anti-VEGF type effect. Based on this, the 190 patients, they got funding and moved forward to 2 big trials. This is 400 patients per arm in both Lugano and Lucia. That's for AMD. And then moving to a DME trial, Como and Capri, also big trials. We're going to quickly switch base to the other TKI that's in phase 3 trials. This is also actually exitinib. It's in another sustained release device. Exitinib is probably 100 times more potent at VEGF2 receptor than is vorolanib. And it does not block all these other things. So depending on who you talk to, that's a good thing or a bad thing. It's not they would say it's not a shotgun, it's a targeted anti-VEGF, and here's some pictures of it eroding over time. Let's see what patient data we have in this. It's a lot less and over a more period of time. This is 23 patients in Australia, phase 1. Had about 6 in each arm, had a long time. This is the pandemic, remember. And there's a 200 milligram arm, a 400 milligram arm, a 600, and then some who got mixed dosing. And the retreatment was pretty wishy-washy. It was really when the investigator wanted to treat, and they didn't like to treat a lot, so it actually worked pretty well without a whole lot of other treatments. The visual acuity, again, it looks like it's longer acting, but you certainly don't have a controlled reason to retreat. Here's the center subfield thickness, at least for 3 or 4 months. It stays the same. Again, it's a hodgepodge. It's lower doses. Some of them have anti-VEGF with it. This is treatment naive alone. Here you see a nice OCT reduction, so at least you know that you've got some anti-VEGF response there. The visual acuity, not as good as I would have liked, but again, the retreatments weren't as solid as most trials. In the US, based on this, they went to 15 patients that were previously treated in dry. So you were treated with an anti-VEGF and dry, and then they enrolled you. They gave you exitinib, and then they gave you an aflibercept, and then they saw how you did against aflibercept. And again, not many needed treatments, but again, these were a dry population on anti-VEGF. So the data doesn't look bad. Mean change in visual acuity, pretty stable OCT. Safety looks good. We didn't see any troubles, even though these are small sample sizes. They then did an NPDR study, 13 patients treated, no side effects. Here you see they had 3 patients with 1-step improvement, 3 patients with 2-step improvement, 7 with none. That was better than control. Maybe they got lucky. Maybe it is really good at decreasing PDR. And based on this, really big studies, 344 in SOL-1. SOL-1's a very unique study. It's superiority over a single shot of aflibercept. We all know a single shot of aflibercept doesn't work very well. But you think you're going to have to get the rescue. Rescue, in theory, requires 2 to 3 lines of visual acuity loss. It's fully enrolled, though, so the horse race is off. This is SOL-R, which is treatment non-naive. It's even harder to explain with 3 doses of aflibercept, 2 evaluation visits, another dose of aflibercept, and then exitinib. But again, fully enrolled, 555 patients. In summary, we got 4 big trials out there. Stay tuned. I don't think we have as much phase 1 and 2 data as we'd like to know how they're going to do. We really hope that these are positive, so we have more agents for our patients. Stay tuned.
Excellent talk, Dave. Thank you so much. Next up, my good friend, Dr. Michael Singer, is going to share some first-time clinical results from a phase 2 study looking at subcutaneous migaldendronib, a first-in-class nanomedicine for wet AMD and DME. Mike.
Thank you for the organizing committee for inviting me. Yeah, it's a hard word to say. These are my financial disclosures. I do contracted research, and I consult for Ashvata. So migaldendronib, it's a word you'd never heard of, but a word that you're going to learn a lot about. It's a novel targeted nanomedicine for bilateral treatment of retinal disease. And what it is called the hydroxydendronib. It is different than just a TKI. It's covalently linked to a VEGF receptor TKI. It shuts down VEGF expression and restores normal signaling. It targets macrophages, microglia, and hypoxic RPE. So it's really important. These are inflamed cells. And you can treat both eyes in one shot, literally, because it's a sub-Q administration. It's cleared by the kidney and not the liver, which was a problem with other systemically given TKIs. And you can see on the left it blocks all major forms of VEGF. So the phase 2 study was looking for true responders. What we did was we looked at people who were previously treated and we gave them a shot of aflibercept and we watched them over a 12-week period. What we wanted is we wanted people who could show response to aflibercept, but not too good, kind of like the Goldilocks effect. You didn't want people who dried all the way for 12 weeks, and you didn't want people who basically never dried. You wanted people who dried and reswelled up. And the number that they reswelled up was their individual personalized baseline. They were given aflibercept along with migdaldendronib, and this is a sub-Q injection given either monthly or every 2 weeks for AMD and DME. And the rescue criteria was CST above the individual's personalized baseline when they swelled back up, or a 10-letter loss, or new or increased macular hemorrhage, or clinical deterioration of the non-steady eye, because the non-steady eye was included, but the worst seeing eye was the eye that was treated. And you can see here by looking at the demographics that in DME you had about 88% bilateral and AMD about 57% bilateral. The study eye in both were about between 4 and 5 shots given in AMD and DME, so these people have been treated before. Even in the fellow eye, they had about 4 shots given before. So again, the study eye was worse, so the OCT was thicker in DME and AMD. What's important, there were no clinically significant change in baseline renal, hepatic, or cardiac events while on study, because that's what we worry about TKIs. There were no ocular or systemic SAEs deemed to be related to the MGB. There was the biggest reaction people had was injection site reaction, and essentially they were mild and pretty well responsive very quickly, and none were severe. So how did it do? So the efficacy showed in this population, you were able to gain 6 letters in DME and essentially 4 letters, almost 5 letters in AMD. You're able to dry out about 23 microns in DME, and then in AMD about 64 microns. You could see this is your waterfall plots, and you can see it was about a 79% reduction in your DME patients and an 83% reduction in number of injections these people needed once they got MGB. In the fellow eye, because when we were watching the fellow eye, it kept everything stable, which was really nice to see, because guess what? The fellow eye did not get an aflibercept at baseline running forward, and they got almost a 90% reduction in their treatment burden by being exposed to MGB. So what we learned, this is the first time we presented the end of study, which essentially is the 40-week top-line data. This was pretty much right in line with what the 24-week interim data that I presented before. It is safe and well tolerated. There are no safety issues as seen in other systemic TKIs. Has a good profile. It's a great way to give drops. Drops give shots by sub-Q administration, single dosing, bilateral disease, clinically meaningful increase in BCVA and CST and DME, consistent improvement in BCVA and CST in wet AMD, stable BCVA and DME and wet AMD in the fellow eye, which is great, okay, and marked reduction for supplemental IVT injection in both eyes. So what's really nice is recently the FDA gave them guidance to go forward with a phase 2b/3 study using the same protocol. So we're very excited to see how this progresses in the first part of next year. Thank you for your attention.
Very exciting, Michael. Now I have the pleasure of introducing Dr. Lejla Vezovic, who will give us an update. We're going to switch the slides back to Dr. Vezovic, an update on vector therapy and how we can incorporate it in our retinal practice. Thanks, Lejla.
Thank you, thank you. Thank you all for having me here. Super excited to be here with all of you, and very excited to talk about vector therapy and gene therapy in general. I do want to disclose I do serve as an investigator in several clinical trials and a lead investigator in some of them. Those are my disclosures. I'm sure you've heard much about neovascular immunization, but really the treatment burden continues to be what all of us talk about, what really report on our PAT surveys on ASRS, and really need to improve that for our patients is definitely there. And why do we talk about it? Because we see that treatment burden in our clinic, where we know the clinical trial results are giving us excellent visual acuity outcomes, giving us really opportunity to extend this patient in terms of clinical care. But when it comes to real world, those numbers definitely drop down in terms of visual gains, but also follow-up for certain. So it's not really uncommon to talk about that really the biggest need, I think, in retina is greater durability for therapies. And I'm also very excited to see that the survey results from multiple meetings, including ASRS PAT survey, shows that we as retina specialists are excited about next frontier, and gene therapy seems to be the most exciting therapy we are talking about. So naturally, when we talk about vectors, we were talking about really viruses that are packaged to deliver genes to help us really create those biofactories, for example, in common retinal diseases, and create proteins that are needed or routinely injected in form of injection in our clinic. And there's lots of ideas and lots of ongoing clinical trials to look at how to deliver these in the eye and for rare retinal diseases, but even more exciting thing for common retinal diseases such as AMD and DR. And there are ways you can deliver. You can do intravitreal, which we're all very used to, in-office procedure. Suprachoroidal is a very novel, but it would be another in-office procedure and convenient for all our patients and us in general. And subretinal clinically is the gold standard and has been the longest studied in all of the programs and continues to be very much studied for common retinal diseases. So I mentioned intravitreal approach. I think technically very easy, but one has to be very much cognizant that inflammation can be a risk, and nonetheless, with the newer vectors, with really appropriate targeting doses, we see less and less inflammation. Most critically is really prophylactic therapy, and I'll talk about trials and definitions of how we have evolved in care of the patients with intravitreal approach. I mentioned subretinal being the gold standard and longest therapy studied. Why? Because we're really delivering in subretinal space, the immunoprivileged area, and it's amazing how quiet these eyes after a retinal surgery, after a surgery itself are, and I'm always impressed to see minimal inflammation with any approaches in subretinal. But nonetheless, the areas where we do deliver the therapy, we are seeing changes and pigmentary changes are noticed, and I think that truly is an effect of all of the gene therapies that are being studied. The suprachoroidal approach is very novel, as mentioned. We are delivering it in a space that to us before was really not previously investigated. We know that we are delivering it to the front, but it very much reaches to the back, and now we're creating, again, biofactory for common retinal diseases. This is being studied in common retinal diseases, but it most certainly is forthcoming in IRDs as well. And we are well familiar with approved therapies that use this approach to use for inflammatory conditions and very much in-office convenience therapy. For gene therapy approaches, we're using thermal cameras to help us understand where exactly we're injecting, but to make sure it's suprachoroidal space, and it's interesting technology to kind of evolve in clinical trials. So the first program I'm going to cover is RGX-314 program, or ABBV RGX-314. This is really one of the longest programs. This is subretinal approach, as well as now being started in suprachoroidal approaches. It's an AAV vector, delivering a fragment similar to ranibizumab. And the patients in this program, especially in phase 1 and 2, have done extremely well. There's data out to 4 years and soon to be 5 years, showing that really visual acuities are maintained, central retinal thickness are maintained. But I think what's most importantly on this slide as well, showing that there's significant reductions in treatment burden. You saw me starting this presentation with saying treatment burden is the problem we have routinely, and visual acuities aren't maintained for that. So reductions with gene therapy are definitely seen there. And the Atmosphere Center is the pivotal phase 3 trials who now have closed enrollment. It's the largest surgical or ever gene therapy program, enrolling over 1,200 patients across US and international. And I look forward to hearing data about that next year. Suprachoroidal approach for neovascular AMD is also looking promising, with stabilization of best-corrected visual acuity as well as central retinal thickness, and the further programs are on the way. Intravitreal, 2 very amazing programs on the way. Adverum with Exovac, really the longest approach and one that has been studying the longest. This program has really helped us understand what are the doses needed, but also inflammatory changes and prophylaxis, and the need prophylaxis has helped us define the prophylactic therapy for all of these. You'll notice that this is very much making administration of aflibercept, creating a biofactory of that, and they similarly have very much shown longevity of the drug in the eye, with protein levels up to 4 years, showing really a eye as a biofactory creating aflibercept type 4 years out. So as a result, you would want to anticipate that best corrected visual acuities as well as retinal thickness is maintained with significant reductions of treatment burden just with one intravitreal injection. I love seeing case examples because they showcase that this is a previously treated with multiple injections and now receives as a part of clinical trial intravitreal injection of one-time gene therapy and has done well for 4 years out. Really minimal inflammation with appropriate prophylactic therapy, and as I mentioned, this trial has defined as prophylaxis for us. And last program I'm going to highlight is for DMT program, intravitreal approach, as well, with really having a very interesting capsid, a novelty there, with penetrating ILM and potentially reaching those retinal layers and retinal cells more actively. The trial itself is also enrolling in phase 1/2 with promising results with stable visual acuities and retinal thickness and significant reduction in retreatment needs for these patients. So they are enrolling phase 3 not only in US and globally, and all of these gene therapy programs will soon to be reporting to us next year and a year after that. So clearly lots of interest in gene therapy, not only among us, but very much among the entire community. I think it's exciting time ahead for our patients in general. Thank you so much.
Excellent talk, Leila. Thank you very much. And last but not least, to cap off our session, Dr. Karen Wei, who's going to speak about improving the patient experience with intravitreal injections.
Changing the topic a little bit. I'm pleased to present the phase 2b/3 RELIEF trial results, a multi-centered randomized double-masked study looking at the novel antiseptic agent IRX-101 versus 5% povidone iodine for use prior to intravitreal injections. These are our relevant financial disclosures. So as any retina specialist in this room knows, 5% povidone iodine causes at least a mild level of ocular discomfort in most patients, but a subset of patients actually have debilitating ocular pain and corneal toxicity. However, the lack of FDA-approved alternatives leads to near-exclusive use of 5% povidone iodine despite its toxicity. In a formal survey of US retina specialists, this was 50 retina specialists, it was actually estimated that the majority of intravitreal injection patients, 60%, experienced some level of betadine discomfort and sensitivity. Of these 60%, actually half of that, so 1/3, experienced moderate to significant levels of discomfort secondary to betadine. In development is IRX-101, a novel minimally toxic ocular antiseptic agent. It consists of stable aqueous chlorine dioxide. It's a broad-spectrum antimicrobial agent with a novel mechanism of action. IRX-101 has demonstrated superior antimicrobial efficacy compared to 5% povidone iodine. In preclinical studies here, as you can see in the plates down here, IRX-101 actually is able to achieve complete kill of Staph epi and Staph aureus in just 15 to 30 seconds with complete clearance of the clades below, whereas 5% povidone iodine fails to reach these kill levels even with 2 minutes of exposure. On the right, we can see the randomized clinical trial sterile, and it showed that IRX-101 was able to achieve 3 to 5 times increased log reduction of periocular bacterial kill compared to 5% povidone iodine. So why is IRX-101 so good at killing bacteria? Essentially, IRX-101 is a high-level disinfectant agent, and it's a very strong oxidizing agent. Essentially, its ability to oxidize is able to disrupt multiple vital cell processes, as we can see here, and it's able to lead to rapid cell death of different microorganisms. So the RELIEF trial was a phase 2b/3 study. In this study, patients were randomized 2-to-1 to receive either IRX-101 or 5% povidone iodine. Patients would undergo their eye exam, get an intravitreal injection with the antiseptic applied first, and then corneal fluorescein staining was checked 2 to 5 minutes after with pain levels assessed at 1 hour. AEs were assessed at 1 hour 1 week after injection. The primary endpoints in the study were looking at mean corneal fluorescein staining 2 to 5 minutes after, and then mean pain levels 1 hour after injection. To preserve masking in both groups, the antiseptic, either IRX-101 or 5% povidone iodine, was applied for 30 seconds. MD would inject, and then there would be a 15-second thorough rinse. For the results, so there were 7 sites that participated in the clinical trial, and overall baseline demographics were pretty well matched between the groups. Notably, looking at anesthetic, gender, ethnicity, and race, there were balanced breakdowns between the groups, but looking at anesthesia in particular, about half the patients in both the IRX-101 group and the 5% povidone iodine group either received subconjunctival or topical eye drops. IRX-101 met primary endpoint 1 with a high level of statistical significance. IRX-101 showed a 50% reduction in pain compared to 5% povidone iodine. Actually, in this group, 50% of the IRX-101 patients actually reported a 0 out of 10 pain level 1 hour after injection. And of over 100 patients treated with IRX-101, the highest pain score was a 4 out of 10. And this is in contrast to povidone iodine, which was a 9 out of 10. IRX-101 also met primary endpoint 2 with a high level of statistical significance and showed a 25% reduction in corneal fluorescein staining scores. In terms of looking at subject exploratory, or our exploratory endpoint, looking at subject preference endpoints, patients who got IRX-101 were twice as likely to report that they were happier compared to prior injections, and 5 times less likely to report that they were unhappy compared to prior injections. Overall, IRX-101 was well tolerated with a 32% reduction in treatment-related ocular AEs compared to 5% povidone iodine. There are no serious, severe, or life-threatening AEs in either group. Notably, the AEs that were most commonly reported were things like eye pain, ocular hyperemia, foreign body sensation, ocular discomfort, all things that we see pretty normally with injections. But all these rates were much lower in the IRX-101 group versus the 5% povidone iodine group. So in summary, the randomized pivotal clinical trial STERIL met its primary endpoint and showed a 3 to 5 increased log reduction in periocular bacterial killing ability with IRX-101 versus 5% povidone iodine. In the RELIEF study, which was a phase 2b/3 study, IRX-101 was superior in reduction of post-intravitreal injection pain, corneal fluorescein staining, and subject preference endpoint for IRX-101. There was also a superior safety profile. In summary, these findings support continued development of IRX-101 as a novel ocular antiseptic agent with better tolerability, efficacy, and safety compared to 5% povidone iodine. Thank you.
Wonderful. We're going to have our panel discussion now and invite anybody from the audience to come to the front microphone if you have any comments or questions. Christina, this was amazing. So much brain power and new information. I'll start off with the first question. Maybe for Dr. David Brown, tyrosine kinase inhibitors. It's a hot topic, a lot of pivotal clinical trials. If they're positive, how would you incorporate this into your clinical practice?
A lot of it depends on what happens in those trials, right? You know, if they really keep the patients dry and they can really go longer than, we don't have any drug on the market, despite what you read on TV, that every patient can go 5 weeks. If you can get every patient to even 8 weeks, you'll take over the market. If you can get some patients to 3 or 4 months, like the TV, people are going to be, beating a path to their door. We'll find out what happens.
I've got a question for Mike Singer. Really interesting talk, Mike, as always. You talked about something that is being delivered systemically with subcutaneous administration, and it makes me think about some of the new agents that Diana was just talking about coming out potentially in the next few years that might allow patients to go a lot longer than what we are typically used to. For those types of drugs, or for something that like what you discussed, where patients might be able to deliver and administer at home, how are we going to monitor these patients and how they're doing?
That's a great question. And obviously, as I'm looking at Anat in the second row, who's going to talk about home OCT, I truly believe that's going to be part of the integration process. The home monitoring process is going to be very important, and I'm really sure it'll be interesting to see how it all comes out, because I don't believe, and I think even more with a systemically administered medicine, we may have minor little peaks and troughs, but I do think that over time, we're going to need different ways to give different medicines with different mechanisms of action, because when it's all said and done, in oncology, if you had, God forbid, get diagnosed with breast cancer, you get personalized medicine with a cocktail based on your genetics. We're going to get them into that point as well. We're going to have to evolve how we treat people, because initially you're still going to probably bring people back, right? Because it's just the way we are, and then you're going to extend them going forward, whether or not you give them a shot. What is nice to know when they miss their appointments, if they're at least they're compliant at home, you feel that they're not going to lose vision, and obviously in wet AMD that's a big deal. So I think the home OCT is going to be a big help. I think it's going to change our practice patterns. But what I've learned from all my years in retina is retina specialists are one of the most adaptable groups of people I've ever met, and they will pivot to make it work.
Jenny Lim, great review on dual mechanism and then aflibercept 8 milligrams. It's interesting how retina specialists still prefer aflibercept 2 milligrams. How do you approach a patient in your clinical practice now that we have a variety of choices?
You know, that's a great question, Diana. And if it's a treatment-naive patient, I look at the biomarkers that are present. And I look to see, are there features in that eye that would make me reach for a second-generation drug? I.e., you know, is there a PED? Is this a patient that has been difficult to treat before? You know, is there more SHRM present? Features such as that might make me want to get a drug that has more efficacy, if you will, and more durability. And then the other thing, too, is in terms of durability, when I talk to my patients who are already on successful treatment but require frequent treatment, I say, well, you know, we have newer drugs that have the potential to go a little bit longer. And some of these patients, as you know, are reluctant to switch. They say, why should I switch? My visual acuity is great. I don't mind coming in if I'm on a, you know, every 8-week interval. They may not want to take the risk of trying a newer drug. And I think that's part of the reason that there's not a higher uptake, I think, of aflibercept 8 milligrams than the people who are on aflibercept 2 milligrams.
We have a couple questions from the audience, Anat.
Yeah, I have two questions. First of all, Jenny, I really liked your talk. I think it's, you know, very brave to compare the two, these two agents. At the end of the day, I didn't see any difference in your data, except the incidence of intraocular inflammation. Did I get it right? So did I get it correct from your presentation that in the Eylea 8 milligram there is more intraocular inflammation or not?
Yes and no. So this is real-world data. So there are reports coming out showing higher rates of IOI in the German population where they look 4 days after the injection, and then in the Japanese population. And so the question is, in Japan, is there something different in the population, maybe genetically, that gives them a predisposition to be more inflammatory to some of the excipients maybe, or to the molecule itself? We can't answer that.
And you don't have on faricimab from the same populations?
And we do not have the same for the first yet. Faricimab is being used in Japan, and there's not been a report out that is similar to what was seen there. Now, again, then with faricimab, we have the occlusive vasculitis, and it's 0.06% per 10,000, or 0.06 per 10,000 is what is felt to be the incidence rates from all the injections. And again, that's real-world data, and for things that are so rare, as you know, not unless you have 20, 30,000 patients, you're not going to get that incidence in the pivotal trials. And so that's why I think there's a difference. That being said, I think if you look at the head-to-head comparisons, you know, and I was afraid to put the matched network meta-analysis data up there because that was looking at the first 12 weeks.
You're not that brave.
Yes, and that study, you know, is you can do it because the aflibercept 8 milligrams was compared to aflibercept 2, and the faricimab 6 milligrams was compared to aflibercept 2. So your similar linchpin, if you will, is a aflibercept 2 milligrams. So you can therefore do a matched network meta-analysis where you fix the populations to make them similar to each other. And when you do that, you still see there is no difference in visual acuity. However, there is a difference in the drying effect. And the question is whether that little bit of difference in the drying effect, is that clinically relevant? Right? And so there's been no head-to-head comparison of the two drugs going head-to-head long-term wise to see what is the final outcome of that. But some people believe that this may be due to the anti-Ang2 component, and maybe that's how you're getting just that little bit more drying early on, and that little bit of faster drying, right, that we see in the DME patients on average 40 weeks to hit that 50 percentile of dry happens sooner for the faricimab eyes than it did for the aflibercept 2 milligram eyes. And I realize also that the aflibercept 8 milligrams is also being analyzed with regards to the 2, and new studies are coming out showing that it is drying it a little bit better than the aflibercept 2 milligrams. So we'll see going forwards.
Thank you. I also have a question about the replacement for iodine, because I do have these patients very rarely that suffer a lot. And I don't know if it's from the iodine or from the anesthesia, but I have one patient in mind. And the question is, and it's actually, you just gave a good segue, the event of endophthalmitis is so rare that I don't know, it will take a lot to convince me to move from iodine, because in any event, it's rare. So I just want to ask the panel about how confident would you be to not to put povidone iodine?
Thanks for the question. Is this on? Yes. Just like you said, I agree. Endophthalmitis, thankfully, is an incredibly rare event, 1 in 2,000, 1 in 3,000. So talking to the FDA, there's not a great way to design a study that would be able to truly see if we can lower the rate of endophthalmitis, or at least equitable rate of endophthalmitis. So the FDA instead uses surrogate testing. They're aware of this. And the surrogate testing in this case is looking at the ability of IRX-101 or 5% povidone iodine to kill bacteria on the skin. So we've done a lot of periocular skin studies, for example, and even preclinical studies, and we've seen that IRX-101 is not only better at killing bacteria, but also faster at killing bacteria. So I would venture to say, and of course we need a lot of real-world data to know this, that hopefully IRX-101 will be as efficacious in preventing endophthalmitis or even better.
Thank you. Let's go to Ursula in the back.
So we always talk about drying out and drying, but drying is not like drying because intraretinal fluid, as we know, goes away immediately, and it is happening with almost every drug and almost every dosage. That is different when you switch to other compartments like subretinal fluid or PED. And Jennifer, you were brave enough to mention PED at least twice, because for PED you need a much higher dosage. That is visible in every single drug. But PED is most relevant for long-term visual maintenance because this is where the lesion, the neovascularization, is sleeping or not sleeping. And this is where we find the angiofibrotic switch. This is where fibrosis comes in and ruins long-term visual acuity. So should we have a closer look on PED?
I think
I'm not talking about just serious PED. I'm talking about long-term PED, which reacts in terms of volume very nicely to any high-dose therapy, but not to the low-dose therapy.
So you're referring to the fibrovascular part of the PED, which is extremely hard to get rid of, as you know. You can just kind of keep it in check, as opposed to the serous component, as you mentioned, which comes down rather quickly. And I think you're right. I think we have to go long-term wise and look backwards and see what is happening to that component and what is the visual acuity doing, what atrophy is developing, yes or no, and see what we can see. So far, in terms of analyses, I think for both drugs, they have not been seeing a lot of atrophy, and they've been seeing maintenance of visual acuity, which is heartening.
And to the not atrophy, but fibrosis that you see when the PED volume is bigger. And there are not many studies that looked at this.
So we were involved with the high-dose aflibercept PED trial because I looked at Jenny and she was my muse, as I told her before, to see what it was there. And it seemed to have a better control of the fibrovascular PED at 8 milligrams than 2 milligrams, so the fibrovascular component. But to your point, they haven't really dug in the Pulsar trial to see how much fibrosis there is. So, but to your point, we may not be able to see it in this population, but I think it's worth looking for it for sure.
Hendrik Scholl.
Yes, this is a question for Leila or for the whole panel. I'm not sure if the statement that there is limited inflammation after gene therapy is correct like that. Just to give an example, I had the honor to introduce the ophthalmic research lecturer last Saturday at the EVO Congress, Bart Leroy, who performed the first gene therapy ever, Luxturna, right? And he showed images of the first patient that was treated. And 9 years later, there's complete atrophy of exactly the posterior pole where the bleb was, right? So this is 9 years later, and he speculated, of course it's all speculation, that this must be secondary to inflammation after subretinal delivery of quite a high dose, right? And by the way, we don't really know the dose that we are applying, right? We take 11 to the 10 to the 3.11, and this is a huge dose for a couple of photoreceptors in the very center. So in my opinion, there are huge unknowns, including inflammation, and I'm not sure if the statement is correct that there is limited inflammation.
Thank you for that comment, and agree. I completely agree with you there. There have been a lot of learnings in gene therapy process and just in general all of these clinical trials. And I agree with you that we have, as a result, dropped our doses significantly in all of the ongoing currently trials, but the learnings are there. I most certainly have had patients in dose escalating trials where we unfortunately have seen dose limiting toxicity and severe inflammation related to that. But my statement was more approaching the current doses that are being studied, that we're not truly seeing inflammation. But you're right, it's unknown, and who knows what's going to happen in 5, 10 years and all of that. All of these factors are unknown.
Good.
I have a few questions to Dr. Singer. Excuse my ignorance, but could you tell us what is MGB? What is the molecular size? Is there any immune response after subcutaneous administration? And what is the bioavailability?
Okay, I'll just take one at a time. So basically, it's a much bigger molecule, than our typical anti-VEGF medicines. In terms of trying to figure out, in terms of inflammation, the only inflammation that we would get, and I'm not even sure I called it inflammation, was the fact that I told you there was a small number of people who had injection site reactions. So in that regards, it really wasn't an issue. What's interesting to understand from an inflammatory standpoint, there was this stuff called, I think it's TYX82, that used to be given systemically, and that was stopped because a lot of inflammation that involved the liver. What's interesting, this medicine is filtered by the kidneys, and we didn't see any significant changes in both the liver, kidney, or cardiac, which has history of TKI issues in other medicines and seen in this. So it's pretty well tolerated from a systemic standpoint. And like I said, the biggest thing we had was injection site reactions. What was it? You had a bunch of questions. Hopefully I got some.
Bioavailability?
Bioavailability, I don't have that data on, but I'm sure the company is looking to it going forward. But I mean, it definitely seems to have a therapeutic effect, because the original clinical trials did show bioavailability because it attacked highly inflamed cells and microglia, but I don't have the bioavailability data on top of me, but I can actually check and see if I can get back to you on that.
Thank you.
Prithvi?
Question to the group. So, Michael, you made a comment that the retina surgeons are very flexible in using new therapies, and I agree with that. But we saw from the first talks that everyone's very comfortable with injections. We also saw that there's a lot of comparators to an intravitreal injection. So to the panel, if there's a new delivery system that is coming forward, what's the bar for adapting, say, a suprachoroidal or a subcutaneous? Because we're all very comfortable with just injecting, and then something has to be better than just non-inferior for that to happen. So we talked about different mechanisms. I'm curious, what's it going to take to change our injection patterns?
So I think the question is, there are two people involved in this process, right? Is it we're talking about retina surgeon, or we're talking about patients? So I do think new things are going to come down the pike. In geographic atrophy, right, we've got the STEALTH study where people are basically going to, STEALTH and Sienna, they're going to be giving at-home, injections there, or they're going to be injected in the office. So I think that paradigm shift is going to happen whether we like it or not as more drugs get approved. To your point, though, retina surgeons are creatures of habit, and they're, it falls into, we have the PDS, which is approved, and it hasn't had widespread adoption because they compare it to things that are already there. Look at faricimab. So it's a bit of a harder sell. But I do think the concept of being able to supplement it in other ways that basically doesn't change our anti-VEGF protocols will be more quickly adapted. But I do think, to your point, they're going to talk about eye drops for Oculus and other things of that nature. I think, you'll have people that are early adopters and people who are later adopters. I don't know what pushes the tide. Dave probably can give me a better idea.
No, I mean, it's amazing that our first anti-VEGFs were so safe, right? We come to the conclusion that really only way we can hurt somebody is that 1 in 3,000 or 1 in 4,000 of endophthalmitis, which makes it an incredibly tough bar. I mean, brolucizumab, great drug, better drying agent, 1 in 200 side effect profile killed it. They don't have any sales staff. There's no sales in the United States. That makes things like gene therapy and everything else just such a high bar because of our safety. Hopefully we'll find it, but doctors won't accept 1 or 2% inflammation.
But I think also, obviously we're talking about all these future therapies that are going to cut down on burden, but we want to talk about also efficacy. Is there something that's actually going to keep our visual cues, or maybe, superior is going to benefit for the patients? I was just at iCellular where lots of companies are presenting new mechanism of action. I'm actually super excited to see Wnt pathway being studied. Not just talk about anti-VEGF blockade. We definitely need to attack it from other areas, and that's what's exciting, is that for the first time ever, we have superiority trial. Yeah, the trial is designed, definitely is being questioned and all stuff, but we do need to look at superiority, not just non-inferior and continue to inject. We need to look at the other ways of taking care of our patients.
Ursula?
Just a short and maybe completely naive question, but what makes us so sure that it's inflammation in gene therapy that causes long-term death of the photoreceptors and not just the gene therapy itself?
Yeah, no, Ursula, that's exactly a comment well said. We don't know. We don't know if this really, we're changing the cells themselves to now production cells, and over time they, just die from that change. There's a lot of unknowns. We most certainly don't know. It could be just mechanism of action as well.
Well, great discussion. I want to thank all of our panelists for their excellent talks. Thank you to my co-moderator, Dr. Diana Doe. Always a pleasure to work together. And thank you for your attention. We're going to move on now to John Miller and Darius Moshfeghi, as well as their panel, who are going to talk about therapies that can change clinical practice. Thanks.
Thank you. It's good. Thanks.
Good to see you. Great job.
How are you, my friend? How are you?
All right. Well, I am very excited to be co-moderating with my esteemed co-moderator, Darius Moshfeghi. It's going to be a really fun and exciting session. We will try to stay on time per our boss, Prithvi. Our first speaker is Dr. David Boyer, who's speaking about integrating photobiomodulation into a busy practice. I think this is a really important topic with recent approval, and I look forward to hearing it.
Thank you very much. Thank you for allowing me to speak today. These are my financial disclosures. I'm a consultant for Lumathera who did this trial. So November 4th, 2024, light therapy technology was authorized, which means it was cleared by the FDA for use in treating dry AMD, intermediate macular degeneration, but was not formally approved. It is a light therapy. It is not a laser. We'll talk about that. How does it work? Well, 3 different wavelengths of light were used, 590, 660, and 850. And basically, these wavelengths of light, when applied to the photoreceptors and to the pigment epithelium, reduced inflammation, caused vasodilation, and improved cytochrome C and mitochondrial function. These patients included were patients with intermediate AMD, visual acuity of 2032 to 2070, the presence of at least 3 medium drusen or 1 large druse greater than 125 microns, and non-central geographic atrophy. The absence of neovascular maculopathy or center-involving geographic atrophy was an exclusion criteria. It was a 24-month trial, and there is an extension. Patients received treatment, each eye, approximately for 5 minutes, 3 times a week for 3 weeks, so a total of 9 treatments over 3 to 5 weeks, and they were evaluated and treated again every 4 months. So you can see here over the period of 24 months, 6 treatments were applied. The Duke Reading Center was used to grade the images, and this study was done at 10 very, very sophisticated places, including Wills Eye, Stanford, Duke, and New York Eye and Ear in our study. It looked for GA analysis, drusen volume, an assessment of EZ of macular location. These are the baseline characteristics of this group, and as you can see, it's a typical group, 75 years old, mostly females, and basically having a fairly mild to moderate amount of GA. Most of the patients had intermediate GA, and overall, the group had about a 3.4 if you use the Klein scale of determining the degree of atrophy. Here's the trial profile. we'll go through. And here's the efficacy. You can see here that within a very short period of time, the vision improved, was maintained at about 5 letters. And you can see there was an initial improvement in what we call the sham group. And the sham group did receive light, so it was not a question that they were totally sham. But I think this was a regression to the mean over the period of time. This is an argument I have with the company. They say it was the development of GA in the center. But you can see there was a definite delta between the two groups, the sham and treated group, at the end of 24 months. Well, let's look at the best corrected visual improvements at month 13, 21, and 24. And you can certainly see the greater than 5, 10, or 15 letters favored the treated group versus the sham. The disease progression from incident geographic atrophy certainly favored the group that was treated compared to the group that was a sham group, with 24% at 24 months developing GA as compared to about 7%. Other studies or other things that were seen was if the vision was worse, and if you come in and your vision's 20/40 or 20/30, very hard to get you to, to improve 5 letters. But if you come in at 20/60, it's a very easy chance of being able to gain vision. And you can see here almost a 7-8 letter improvement in the patients who had less vision compared to the patients with good vision. Other things that were found, the VFQ showed a definite improvement, a reduction in incident GA and other exploratory markers, and conversion of GA to CROR, all were reduced in the treated group. Had a very favorable safety profile with no signs of phototoxicity, no deterioration in other visual outcomes. There was, however, a slight increase in the amount of patients going on to developing neovascular AMD. A short note to let you know about the add-on trial. There was a period of time that over 20 weeks that no treatment was administered. You can see the visual acuity went down, and then when treated, the vision went back up. And this is the difference between the sham group during this period and the treated group. You can see a very large difference. So basically, the study did demonstrate a visual acuity improvement. Retreatment brought the patients back after 20 months off, and the larger visual gains were afforded with patients that were receiving constant treatment. Thank you very much.
Thank you, David. Can we have all the speakers come on up right now to facilitate turnover? And then our next speaker is going to be David Eichenbaum, who's going to be speaking on enrollment efficiency and enrichment for candidate identification in geographic atrophy and with an AI-driven workflow. David?
Thanks, Darius. Thanks, John. I'm happy to be here. Thanks to my friends at Stanford for inviting me. I'm David Eichenbaum, and I'm excited to present this proof of concept collaboration between our site and Retina AI, looking at enrollment efficiency and enrichment with candidate identification and geographic atrophy with an AI-driven workflow. In the words of my mentor, Dave Brown, I'm a highly conflicted individual. I am an investigator and a consultant for Retina AI. The proof of concept study had 2 parts. The first was demonstrate the feasibility of the AI-driven workflow, and the second was to compare this to our actual historical screens. The methodology is we first did retrospective analysis of our own clinic during the GATHER1 and GATHER2 enrollment periods. Following that, we did automated imaging upload using the Retina AI technology, which grabs the images, de-identifies them, and then plugs in the biomarkers that we programmed into the system. Thirdly, we compared this imaging workflow to EMR data. And lastly, we had a qualified candidate list that we then compared to our historical screenings. These are the windows in which we enrolled patients. We looked at patients 6 months prior to the GATHER1 and GATHER2 enrollment periods at our own site. We then looked at patients every 3 months during the GATHER1 and GATHER2 enrollment periods. This is a cool slide. The left side of the slide shows the actual GATHER study protocol imaging criteria. This was from the GATHER studies. The right side shows what we put in to the biomarkers in Retina AI to mimic the GATHER2 clinical trial imaging manual requirements for inclusion and exclusion. This is what we actually did. We screened 26 patients, we screen failed 20, we enrolled 6. 90% of our screen fails were because of imaging. Here's how the flow goes for the AI filtration of the images. 4,000 individual subjects were looked at in our RVAF, our practices database. 90% of them were automatically filtered out due to the geographic atrophy and/or fluid presence. Another 6% or so because of our proxy for central involvement, which was exclusion in Gather 1 and Gather 2. And then another 1% or so because the GA was in the wrong place. We did that again with Gather 2. We did a similar filtration, and that generated again a number of potentially eligible subjects. Now, there was some overlap between these two because of the 6-month look back in Gather 2, so we had a total of 270 unique subjects. We then filtered those patients further based on the electronic medical records data, and that gave us potentially 24 perfect subjects. That's pretty neat. We'll go into those subjects in a little bit more depth. This is another way to look at the way that we acquired the subjects. Looking at the 6-month look back in Gather 1, we have a dark blue column showing 21 subjects filtered by imaging. Those patients who we identified were carried forward and looked at again every 3 months in the dark blue columns. Light blue columns are patients who were introduced either by referral or return to the clinic who made it through the AI workflow and met the criteria by imaging. Cross-referencing with the actual clinical data in the EMR, we generated 12 candidates in Gather 1. Historically, in this actual period, we enrolled 3 and screened 8. Here's the same flow for Gather 2. Dark blue columns looking at the 6-month look back. They're reevaluated every 3 months. Light blue columns are patients who come in. Another 12 patients in the Gather 2 analysis period. We actually enrolled in real life 3 of 18 screens in that period. So the left side, again, this is what we did. 26 screens, 20 screen fails, 6 enrollments. In the AI-driven workflow, 24 potentially perfect patients who could have been potentially, theoretically, 100% enrolled. Now let's look at those patients again. Left side is our historical patients. Of the 26 patients we screened, 24 had images that we could feed into the AI system. Of those 24 patients with imaging, 19 screen failed, we enrolled 5. Looking at those same 24 patients with the Retina AI technology, pushing them through the workflow, we had 18 excluded by imaging, 2 excluded by EMR. 4 of our same 5 patients went in with 100% enrollment efficiency versus 20% or so that we achieved in real life. What does this look like? This is a patient who was in the AI-driven workflow and actually enrolled in Gather 2. Here's a patient who was included in the AI-driven workflow and we missed that patient. That patient even told us they wanted to be in a clinical trial. They did eventually get into a trial, but not Gather 1 or Gather 2. In conclusion, the Retina AI workflow increased efficiency by 4-fold versus what we did manually. We enriched the patients by picking the appropriate patients historically. So the AI-driven workflow does have the potential prospectively to identify highly qualified candidates and improve enrollment efficiency. The limitations, of course, is this is retrospective, and 19 of the 24 patients in the ideal patient list were never actually screened, and we don't know what their actual enrollment outcomes would have been. But the future is exciting, and we'd like to see how this works prospectively in real life. Thank you for your attention to this presentation.
Excellent job, David. Our next speaker is Yasir Sepa, talking about OCT-guided microperimetry in geographic atrophy and maculopathies.
Good afternoon, everyone. I wish I was as conflicted as both the Davids before me, but I'm not. Most of my work is supported by the Catalyst Award from RPB, the P30 grant that Byers has, and I am a co-founder at OIRRC, where most of these workflows have been deployed. So a lot of us in the crowd are familiar with this particular paradigm where a lesion that is centrally located doesn't allow you to show a 3-line gain. And if it is not centrally located, that again doesn't allow you to show a 3-line gain. And it becomes quite challenging in drug development to show whether any particular molecule that you are testing has any efficacy and effect on function or not. So functional assessment of the retina has been there for a while. Microperimetry has provided a lot of promise. However, it is a time-consuming process. It is very resource-intensive, and regulatory benchmarks could be challenging. Specifically, showing 7 decibel change in 5 pre-specified points is a challenging criteria to meet. From the chromospectry trials, we did learn that if we try to focus only on the perilesional area, which is where most of the action is happening, we have a better shot at showing changes in retinal sensitivity over a period of time in observational studies and in studies with treatments and interventions. However, in such a scenario, this is an AI-driven, AI-made image of a lesion that is increasing in size. If you do a 10-2 or a traditional, any formula, you apply that for your pattern, you run the risk of having no particular testing points within your transition or perilesional zone, or you have quite a few. So how do we standardize this particular scenario where we have every time for every patient we have the same number of spots that we can put in the zone where we feel like will give us the best data to show whether the drug is active or not? An ideal solution would allow us to eliminate or isolate the dead tissue, which is the geographic atrophy, from the transitional zone and then from the normal retina. This is the first proof of concept patient that we did scan with the algorithm that we have developed. You can see fundus autofluorescence overlaid on OCT, and on top of that is the microperimetry readings. Two things that were evident. The first one was that we could already see retinal sensitivity significant decline in the areas where fundus autofluorescence had not encroached in yet. And this is proven by the same eye scanned 18 months later, where those spots which was showing significant decline in retinal sensitivity were converted into scotomas. Over a period of time in the OREO study, we have shown that in 6 months, you do get anywhere between 3 to 4 decibel loss within the perilesional zone. We have applied this particular method now to fundus autofluorescence anchored microperimetry in Stargardt's as well, where we can show the difference in retinal sensitivity in the QDF and DDF lesion areas, thereby bringing a functional component to potentially as an approvable endpoint in the Stargardt disease as well. Now, what are the challenges? So some of the challenges are in how do you anchor your microperimetry on? What type of lesion? There are different types of lesions within the same eye where you could put your retinal sensitivity spots. This is an example of a grid that was prepared where we isolated the eye aurora and the C aurora lesions, and we put together 3 different rings through which we were prospectively assigning the grid. The second idea, which is now becoming more which is catching on, is, well, the EZ and the RPE maps or heat maps is what should drive where these retinal sensitivity points testings should be. And the third challenge that we still need to figure out is how close can we actually put these points. There is a physics and a mathematical problem that the machine cannot overcome itself. You cannot put the points too close to each other because at that point you are not sure where that particular point is getting the functional data from. So in a sense, our take-home messages are that IGMP allows quantified structure-function correlation. We do address the regulatory requirements, which is the pre-specified region of interest can be assessed. A single strategy for customized patterns does not exist yet. A lot of work needs to be done to figure out what is the standardized or what is the single strategy, and it may never exist. We may have to build different types of strategies for different types of patients within the same indication. And lastly, the impact on clinical trials length and sample size at this point is not known. Of course, this work would not have been possible without my lab and the collaborators that we have. All the manuscripts and the slides are available at this screen. Thank you.
Thank you, Yasser. Our next speaker will be Michael Michaelides, Novel Therapy for Adolescents, Stargardt.
Great. So it's a real pleasure to be able to share data on behalf of the global study team about the DRAGON study. This is a phase 3 study of tinlarebant, an oral therapy for the treatment of Stargardt disease. should have learned how to use this, shouldn't I? Third time lucky. I consult for Belite Bio, who are the sponsor for the study, and I'm also a PI on the DRAGON study. Patients with Stargardt disease carry disease-causing sequence variants in the gene ABCA4. This results in loss of the encoded ABCA4 protein in photoreceptor cells. This interferes with the normal vitamin A recycling, resulting in an accumulation of cytotoxic byproducts of vitamin A, so-called bisretinoids, and these result in progressive retinal cell death. Tinlarebant is a novel, once-a-day tablet designed to bind to serum retinal binding protein 4, RBP4, as a means to specifically reduce the retinol delivery to the eye and thereby slow or halt the accumulation of bisretinoids. Vitamin A is transported in the circulation as a complex bound to RBP4 and transthyretin. Unlike other extrahepatic tissues, the eye has a unique requirement for uptake of retinol, which is bound to RBP4. Once taken into the eye, it is bound to rhodopsin to activate it. Following phototransduction, photoactivation, all transretinal is released from rhodopsin. And that is removed from the retina by ABCA4. In Stargardt disease, that ABCA4 protein is dysfunctional, leading to an accumulation of all-trans retinal, which can spontaneously react with other retinal species, including itself, to dimerize, and also to form complexes with lipids, resulting in cytotoxic bisretinoids and progressive photoreceptor cell dysfunction and death. Tinlarebant is a small molecule. It's an RBP4 antagonist, which has 100-fold greater affinity for RBP4, therefore outcompetes, and the Tinlarebant RBP4 complex is eliminated by the kidney. This results in a reduction in retinol delivery to the eye, and thereby reduction in the generation of the cytotoxic bisretinoids, and thereby anticipated slowing of disease progression. This is from a phase 2 study of adolescents with Stargardt disease. In blue, we see as the Tinlarebant is taken orally once a day, there's an increase in the dose that correlates with a mean reduction of RBP4 levels to approximately 80% relative to baseline. The target threshold chosen of greater than or equal to 70% is based on studies in GA, where such a reduction in RBP4 levels resulted in reduced lesion growth. And then you see at the cessation of taking the medication at the 2-year time point, there is restoration of RBP4 levels. In terms of the phase 3 trial itself, 104 patients were recruited. Global recruitment, including US, UK, Europe, and China. Randomization was 2-to-1 in terms of drug to placebo. It's a 2-year study with the primary endpoint being slowing of atrophic lesion growth in terms of definitely decreased autofluorescence. Other measures were visual acuity, OCT, and microperimetry. There was an interim analysis planned at the outset to be conducted once all subjects had completed month 12 assessments. And in terms of key eligibility criteria, patients were between 12 and 20 years of age, had to have at least one disease-causing sequence variant, had an atrophic lesion size within 3 disc areas, and a BCVA of greater than 2200 or better. In terms of age, the patients were 15 years of age on average. There were about 60% males. In terms of ethnicity, 36% were white and 55% were Asian. The interim analysis was conducted by an independent data safety monitoring board once all patients completed the month 12 assessments. Observation of an efficacy trend within a statistical window called the promising zone of efficacy would allow for 30 additional subjects to be recruited to enhance the power of this observed efficacy trend during the second year of the study. No subjects would be added in case of futility, i.e. below that zone of efficacy, or if the efficacy was beyond the promising zone of efficacy. The DSMB findings were that there was no modification of the study required. The sample size stayed as it was. They deemed that the drug was safe and well tolerated. at the time of the analysis, the interim analysis, the overall withdrawal rate was 9.6%, and with the withdrawal rate in terms of ocular adverse events was 3.8%. They also recommended that the data should be submitted for regulatory review in order to seek drug approval. By the end of July of this year, the last data cut that the DSMB has seen, approximately 90% of patients have completed the study, so out to 2 years, and under both standard and low luminance, visual acuity has remained relatively stable compared to baseline. In terms of safety, xanthopsia and delayed dark adaptation are the most common drug-related ophthalmic AEs, as you would expect from the mechanism of action, and most of those are mild and some even resolved while on treatment. So Tinlarebant has now received breakthrough therapy designation from the FDA based on the interim analysis. The recommendation of the DSMB that the study continue without additional subjects and that the data should be submitted to regulators for consideration of approval shows that the efficacy was beyond that promising zone. Belite Bio is currently in discussions with global regulators to seek the most expeditious path to approval. Thank you.
Thank you, Michael. Our next speaker is Ursula Schmidt-Erfurth, speaking on geographic atrophy progression. Can detection be easier?
I truly appreciate the invitation to talk about geographic atrophy progression because I think it's an important and interesting topic. And the question, can detection be easier? That gave me a lot of headache because what is easy in medicine? I think easy can only mean that it comes with high quality at the same time, so precision. Disclosures first. So what, of course, is easy? Of course, fully automated AI segmentation of GA progression is the easiest we can have in practical terms. There's the GA monitor. It offers AI-based segmentation of 3 major key features, which is ES ellipsoid zone thickness, EZ loss area, and RP loss area as well. We know that disease activity depends strongly on the EZ-RPE ratio because there is a consistent pattern that the blue area, the RPE loss, is filling into where the pre-existing EZ loss is, and this has been verified in every single case that we have seen of thousands. So we know that the more blue there is, the more final the lesion is, the more green there is, the more inactivity it is. We have looked at this at different quartiles based on the different EZ-RPE ratio and found that the fast progressors in the untreated case were the ones that had the larger EZ-RPE ratio, and we can visualize this, and this is the question here: how can we monitor progression easier? Of course, by looking at it by a real-time visualization and quantification. This is one report that you get in real time. That means in a few minutes while the patient is with you, or ideally the patient comes in with a report in his or her hands in your office, and at baseline already you can visualize the level of disease activity, which is the area of the green zone, and not only in numbers and quantification, but you also see the localization. You see whether the fovea is at risk, for instance, which is, of course, very important. So this approach, this accessibility of technology with the RetinSight AI solution is available with different OCT systems. The Spectralis was the first one, as there was the majority of data available. Then, of course, Topcon Triton now. There is also Maestro undergoing, and there is also the Cirrus instrument capable in doing this. RetinSight's AI-based monitoring solution are available with different PAC system, and there is the famous HiX26 Epway version. Then there is the independent web-based Red Hub, and of course the fluid monitor is can also be accessible by Harmony, so will be all the other AI tools. What is important to make this not only easy, but only excessively precise? There are several steps that are classical steps in the development of a high-quality algorithm. First is inspection. You have to make sure that you are not only based on clinical trial data, but also real-world data, because clinical trial data do not cover the full range of potential patients, and the validation may be biased. So you need different sizes, you need different underlying layers, and because we know that drusen have an impact, for instance, and you need different quality of images, and what we introduced now is an automated image quality algorithm as well. The next step is development of data. You want to reach targeted enrichment. So this is the next step that we did, 200 clinical study GA patients and 100 real-world cases, challenging cases, tiny and huge lesions, intermediate AMD, neovascular AMD, healthy eyes. The quality of data is more important than the quantity, and enriching data with problematic cases is key here. Then another painful step is coming, which is ground truth annotation. These refined annotations need a detailed annotation protocol, very precise definitions and consistency in annotation, as we know that the underground underneath the GA lesion is very lumpy, bumpy, and you need to be extremely precise in annotating this. The model development shows that the EEZ layer and loss, which is based on a 2D and 2D to 2D dense network. The Brooks membrane layer algorithm is also 2D to 2D, while the RPE loss is 3D to 2D, and all of them work extremely well. The validation is needed. In addition, on a different data set, which included in this case 43 patients and 43 eyes, which includes 1,000 visits, and a good representation of the target population is key. Why do I say that easy is one thing, but easy is only a value if it is precise enough? So this algorithm, after all the steps that I described to you, has a high correlation between human and the algorithm measurements. And it has what we call a superpixel precision, because the error is as low as 1.5 microns, which is much lower than the distance between 2 pixels. So this is much more precise than just counting individual pixels. And this is what then justifies to say this is easy, because it works well. So in summary, GA progression is a subclinical alteration of the EZ layer. Subclinical is very important, but nevertheless, EZ thinning and loss and RPE loss can be measured objectively and accurately by automated AI tools. That means EZ loss thinning as a novel subclinical biomarker reflects diagnostic disease activity, and progression and therapeutic response in GA can indeed be identified easily and accurately. And I thank all the people who did the hard work. And if there are any complaints, refer to the name that you can read underneath it. I'm the complainers person. So you have your choice. Thank you for your interest.
Thank you, Ursula. Our next speaker will be Anat Lowenstein on home OCT and vision monitoring, real-world data insights. Anat.
Thank you very much. It's a very big pleasure to participate in this INNOVATE meeting and to talk about real-world data insights on home OCT. These two patients look very similar. Both have fluid, subretinal fluid on visit 1 and visit 2. However, actually in between the visits, they differ significantly from one another, as can be seen by this trajectory, which is produced by the home OCT, showing that one patient just had fluid real close to his second visit, whereas the first one had fluid all along. The home OCT measurements here have the potential to assess the disease activity in between the visits and show us deeper insights into the treatment response and temporal course of the disease. This study was performed by Nancy Holcomb and showed that in 15 patients that the interval when they were switched to monitoring by the home OCT increased from 8 to 15.3 weeks. So these results show the potential of the home OCT to reduce the treatment burden. The study, a different study, was performed by Jeff Heyer in collaboration with Nancy. And in this study, patients, the impact of home OCT on treatment decision was studied. When provided with the home OCT data, the physicians had significantly different decisions as compared to what they did when they had the standard of care. In 43%, actually, they decided not to treat, whereas in real life, they did treat. So the home OCT has a potential to influence treatment decisions. We all know what are the significant productivity costs and time spent for doctor's appointment, calculated to be 12 hours, not only for the patient, but also for the caregiver, with more than $1 billion expenses in the United States. And the expenses and the burden are bad enough, but the most significant problem is that they bring along non-adherence and then less good results. This is the workflow of the home OCT. It is prescribed by the ophthalmologist to the monitoring center. The monitoring center sends the device to the patients and gives the support for the regular monitoring. The patient's task is to perform daily OCTs. Then the OCTs are automatically mounted on a cloud, analyzed by AI for intra and sub hyperreflective spaces, and the ophthalmologist reviews the images and the projection maps and the trajectories and sets the threshold for notification. We've shown in multiple studies that the patients are pretty adherent and perform over 6 scans per week. 96% of our really elderly patients are able to start the device, and most of them found the device very easy to use. Many trials look at the adherence, and it is around 6 scans per week, as well as the study which was performed by Nancy Holcomb, part of an interventional trial to understand the adherence, and it was 6.2 scans per week. In the study which I showed you before, where the treatment interval increased to 15.3 weeks, the data showed that patients on average were seen within 3.4 days in the meantime. So no cases of missed visits, and it shows that there is a pretty good adherence to the prescribed treatment. We have excellent treatment nowadays. They were discussed in a previous session. We have faricimab, we have aflibercept 8 milligram, we have TKIs, we have PDS, we have genetic treatment. However, the response of the treatment is pretty heterogeneous between different patients. And even if we talk about 80% that can go for 3 months or more, it's 80%. It's not all of them. And the home monitoring is an ideal tool to account for this heterogeneity. I would like to show you 2 cases. One is a patient that was on the PDS since April of 2022. He skipped the routine refills, and actually he was started monitoring with the home OCT on December 22, and the fluid increase was noted in February 23. Appointment was set to give the refill. And this is a case courtesy of Wagner Kapoor Institute, a patient who was treated by many agents before. In December 2023, there was fluid. He was switched to faricimab, and the 50-day interval was shortened to 42 days. Again, there was fluid. The interval was shortened to 35 days. Then there wasn't any fluid, but the patient wanted it to extend, so he was switched to aflibercept. But again, there was fluid after 44 days, no fluid, and then he was switched back to faricimab. So regardless of what was the treatment, the patient remained on 33 to 35 days interval. Then he was introduced to the home OCT for further optimization, and he was treated according to the home OCT. And by using this modality, the treatment interval was being extended to 44 to 45 days, so about 30% extension of the treatment interval. This shows all the journey of the patient over 40 months, and it's not a magic. It's not something that is magical, but it just shows more granular data that can help us optimize and tailor the patient individually for the patient. And the patient is very happy, and this is also important for us for his compliance. Of course, we'll have a lot more data following protocol AO of the DRCR-NET, and Christina Wong is in the audience, I think. And this trial is going to show us OCT versus treat and extend. All eyes will receive faricimab, and the primary outcome superiority comparison of mean change in visual acuity and number of injections. So we validated the OCT for efficacy and safety. We showed that it has an impact on physicians and on the burden, and it's had the potential to enhance the compliance to treatment and maybe, therefore, also the final outcome. Thank you.
Thank you, Anat. I think we'd like to open it up to questions. We have a little bit of time for a panel discussion. We had some great talks in this session. If anyone from the audience would like to come up to the microphones, Darius can start with a question.
Yeah, first question goes to Dave Boyer. Dave, I was a little surprised that the photobiomodulation got approval just on the basis of the visual acuity results weren't what we're used to seeing, and they got across the line probably on the geographic atrophy, but the numbers were low. Can you address that?
Yeah. So as I said in the beginning, they didn't really get an approval. You're allowed to use it. It's sort of like getting a CE mark in Europe. That's how I liken it to. CE mark in Europe would allow you to use the treatment. It was found to be safe and had some efficacy, but insurance wouldn't pay for it. So in order to, I think, the CMS is going to require a much larger study to look at it, and look at it in a prospective manner with larger numbers. There is something there. I mean, you definitely had a number of secondaries, and the Duke Reading Center showed a number of things that I think we need to look at in detail. But when you look at post-hoc analysis, it's really to generate further discussion and further studies. So they didn't get the approval that you're referring to.
Thank you for that clarification.
I'll ask a question of David Eichenbaum, our second speaker. I thought, congratulations, it was a really nice study. I think this is a really nice application for AI. AI obviously came out really thinking initially applied to DR screening, and I think this is another pinch point for retina specialists is clinical trial screening. So I wanted to ask what are sort of the next steps? Have you looked at multi-center? Have you thought about applying it to other diseases or other ongoing prospective trials that you're doing?
Yeah, so that's a great question, and I get asked that often by AI companies and by sponsors. What would you like to see next? I would like to see AI-driven workflow applied to a prospective clinical trial, at least at some sites, and see if that actually does accelerate enrollment. The data is very encouraging and it's very positive. It is retrospective. We need to test drive it in a clinical trial. I think GA is a pretty good disease state because those patients are kind of hanging out, and it's tough to figure out all the lesion characteristics manually. So you can program them like we did in this retrospective trial, and I would like to apply that prospectively to a GA study in any existing clinical trial site that gets the patients driven from clinic and see how it works. Do we really have sites that are using AI getting much quicker enrollment timelines, or is it really similar to what we've been doing? Because I think we're pretty good as a site, but we could be better. We always strive to do better, and we'd like to see if this is the way, and the way to figure it out is to apply it prospectively and see if it works.
I know that dropout rates is a big discussion point on some of these clinical trial results in many of these studies. Did you look at that, or is that something that you think you could incorporate? We think about demographic data like distance to clinic or access or maybe education.
Yeah, I don't think AI can help us with retention. I wish that there was a button for everything. There's lots of other strategies for retention, but I think this is more for candidate identification and making enrollment more efficient. It's up to the site to get them to stick, and there's lots of ways to make them sticky.
Ursula and then Anat, fabulous discussions. I like the evaluation technology for, particularly on the OCT, for the AI. Is there, how far are we from a future where we can start applying this to a broader population instead of just looking at patients who have AMD or patients who are being monitored from AMD and moving it to, like, I have an iPhone that's just looking at my eye regardless of my age, and it's looking for disease that should be referred to a physician?
So the iPhone question is to me?
Yes.
I think that you should use, not you in person, but in general, people should use their iPhone much less, if you want to have my comment. But, of course, we are talking here in a medical context. So first, we have to bring in automated AI segmentation of whether it may be fluid-related parameters or atrophy-related parameters into the clinic, into clinical trials, into phase 3 clinical trials. This is what we need to show first. This is the evidence that is needed. Then the type of format, it may be an iPhone or whatever we are all using in 3, 4, 5 years from now. But this proof of principle has to be done, and this is probably up to the regulatory agencies. It's up to the companies to have the courage to do so. I do miss the courage in the pharma industry so far for fluid-related studies, because we know that compartments play a role, we know that volumes play a role. I do not really understand the reason why not have a closer look, because PED, for instance, as we discussed previously, has a most important role. And then we can think about iPhones, or what was the question? It was an iPhone
just like
question.
how generalizable is the monitoring technology?
I think it's
using an
very
AI?
generalizable, but it has to go through all the regulatory steps.
I think it is a good direction to trend. I mean, we see CSTs in the last section. I think moving more towards fluid volume is really the direction we should go in all of our clinical trials.
Can I make a comment on that?
And a nod follow-up to Darius.
Anna?
Could I ask David a question about the screening? We also did a study in collaboration with Moorfields, trying to identify the recruitable patients via AI, and it's proved to be pretty effective. My question is that it really depends on the quality of the data. I don't want to say cliches like garbage in, garbage out, but it really depends on that. And I said it. And my question is, so what worries me a bit, even though I think this is what will happen at the end of the day, what worries me a bit is that we might lose many patients that could benefit, and that it's pretty heterogeneous, the data that will be looked at.
Yeah, I think that the filtration and the quality of data that you have for the AI to analyze for imaging is key. You're absolutely right. And that's one of the criticisms about retrospective data. You saw that we refiltered the patients every 3 months. It's like we like quadruple filtered them like Grey Goose vodka to make them perfect and delicious. But in the real world, when you're trying to acquire patients quickly, you would not be able to triple filter them. You'd identify them based on whatever biomarkers you input, whether it's atrophic or exudative or what have you, and then you would drive them to screening. And that's the question, is the data that we're giving to the AI algorithm, regardless if it's Retina AI or anyone else's, is that data good enough to drive enrollment? And that's what we have to find out prospectively. It's easy to look at it retrospectively and compare it to what we actually did and show what a good job we would have done, but we need to see if that can be pressure tested. And I'm excited to try that. You know, we got to see if we can do it.
Definitely, that's where we're going.
Thank you. I think we'll take a question from the audience.
I have two questions, one for AI team over here. Do you think AI will ever be, in the near future, not Star Trek future, be able to annotate images itself, by itself, not training that on annotations? Second is for Dr. Sipa, that DDAF is easy, it's GA, you can detect the edge, but poorly demarcated, questionably decreased autofluorescence, how are you sure you are that you're scanning the same area, and what's your margin of error that you're precisely at the same location or slightly off that location each time you repeat the scan?
So the scan, you mean the microperimetry scan?
Yes, microperimetry target.
So there's two questions over there. It's not just one. So first is the identification of the boundary of the QEDF. We don't do that manually anymore. As you pointed out, humans are not able to identify that edge. So we have an algorithm, StarGauge, which has been validated in collaboration with Belite on their screening data. The margin of error is we can detect half a size of a lesion that a human eye can detect with that. So we use that algorithm to identify the edges. The second question, whether the microperimetry spot is in the same location that we think it is or not, It has to do with, so what microperimetry right now shows you where the point is, it's actually not there already. There is a 0.5 degree halo around it from which it is actually pulling the data. And that's something that we look at a microperimetry PDF and we think that's where the results are coming from, but that's actually not true. So, and that has to do with the tracking ability, the speed at which we can track the saccades of the eye, and the distance between the stimulus. So there are some physics-related problems that we won't be able to solve. But what we can do is we can reliably grab the structural data from that 0.5 degree halo and give you a mean thickness. For example, some of the maps that I showed from EZ, it's not 1B scan. It is from the surrounding area. So we can be fairly precise within that 0.5 degree radius. But yes, what you're seeing actually is not there. There is already some registration error inbuilt into the technology.
But it depends what you're targeting, of course, because you want to target an area that has a disease that is converting fast, because this is what the regulatory agencies need to see, and this is what helps the patient most. And targeting the EZ loss area, for instance, in a safe distance to the intact retina has turned out to be most efficient, because the probability that intact retina, when you just go take these onion ring shapes, there are many points that are intact retina, will switch to an absolute scotoma is around 1.1%. But the probability that an EZ loss will turn into an absolute scotoma within 6 months only is 25%. If you're interested in hearing more about this, please join me tomorrow at the late Friday afternoon at the subspecialty day, so that I'm not all alone for almost the last talk. I think you will greatly enjoy it. Thank you.
I did want to quickly ask
the other piece of the question was annotating images. I do think AI could annotate images. I think that would be, I don't know how valuable that is. I think that's would be a bit of a cool, like a cool feature with AI-powered imaging, but I think that the power of AI goes more to driving populations either in our setting to clinical trials or to treatments that are appropriate. But we do have a lot of images from Retina AI which show how the tagging could occur, and we're going to have a longer format talk, unfortunately not at Subspecialty Day, but at Topgolf tomorrow evening. So you can come and we're going to have more images to review and some
After
videos.
you go to Ursula's. Yeah.
Correct. You can go to Subspecialty Day and then go to Topgolf.
All right, thank you.
I think I wanted to ask Dave one thing, and then I'll go to Anat. Dave, I just was going to give you a chance to, could you just very quickly, top level, how you envision the PBM being rolled out in a busy clinical practice? Like where are you putting it at all your sites? Are you is it given treatment by the retina specialist every time or the first time?
John, that's a great question. These Valeda instruments have popped up in every retinal specialist office in Los Angeles. It's almost like Starbucks. You know, you don't have to go very far to find somebody who's doing it. I think we're only doing it in one center. I think, you know, to be honest with you, I think a lot of patients that are being treated don't need to be treated. You know, patients that have a couple of small drusen, not even in the fovea, and have 20/25 vision are coming in, do I really need this treatment? And since it's really questionable about the reimbursement, I think the biggest question is, if you're going to treat, who is the ideal patient to treat? And I think you have to, you know, go back. I wouldn't use this as a treatment for geographic atrophy because it wasn't meant to show that. It wasn't powered to that ability. And I would use whatever, if you're going to treat, use whatever is available. Semi-soft drusen with some vision loss, 20/40 in my office, I would consider treating because they did have less incidence of getting geographic atrophy when the drusen went away. But we all know drusen come and go. Even, you know, sometimes a very large amount with no GA. So I think there are a lot of unanswered questions, but I tend not to treat very many patients.
Last question.
Last comment. Happy to make a comment. So to you, David, I mean, the clinical trial on PBM, in my opinion, this is selection bias because patients with intermediate AMD simply do not have reduced visual acuity. This was convincingly shown in the Pinnacle study. It was shown in the MacuStar study. But regardless, if there was a proper trial in intermediate AMD, the endpoint shouldn't be visual acuity. It should be incident late AMD, right? And I think this was not studied.
Well, I think what's going to be studied right now, Duke is going back and looking at the OSIS junction to see if there's actually abnormalities that can be seen, if there's less changes in that. Because, you know, these patients do have some decrease in vision, and the patients who had a greater decrease did have a greater improvement.
And with that, Prithvi is running us off
we'll
the
move
stage.
to the next section, session 3. We have Garaj Shah and Prithvi Muthanjaya moderating. Thank you to all of our speakers.
We can have our next set of speakers join us up on stage. So Gaurav, we live 30 miles from each other, but we've come 3,000 miles to sit next to each other on a stage. So why don't you kick us off?
All right. First is going to be by Rishi Singh, Surgical Therapy for McTell from Boston.
Thank you. This is a neat talk that's going to cover some of the surgical pearls as well as the outcomes data for macular telangiectasia. Here are my financial disclosures for the presentation. So we're well aware that macular telangiectasia is a bilateral progressive retinal neurodegenerative disease. It affects the ellipsoid zone, the retinal pigment epithelium, and the photoreceptors within the macula. And we've seen central vision loss and functional impairment in these patients through multiple natural history studies. When Mueller glial cells are inflamed and they have insults, they release ciliary neurotrophic factor as a way of protecting the photoreceptors, and hence by allowing CNTF back in the eye, there might be an opportunity to preserve these cells over time. Encapsulated cell technology is a sustained release delivery system for CNTF. This is a RPE cell line which releases the CNTF over time. Anywhere from 200 to 400 RPE cells are located within a single implant, and revakine is a first-in-class encapsulated cell technology. It houses these allogenic RPE cells, and these release over many, many years. Up to 10 years have been studied within most of the trials. It was actually approved for the FDA for the treatment of adults with MacTel on March 5th of 2025, and now available for implantation. This came after 3 clinical trials were performed. One was a phase 2, and there were 2 phase 3s. They enrolled patients who had macular telangiectasia type 2, and in the phase 2 trial, they looked at the change from baseline in easy area up to month 24, and in the phase 3, they looked at the rate of change of baseline in easy area through month 24. There are a variety of different endpoints looked at here, including reading speed, aggregate retinal sensitivity by microperimetry, and best corrected acuity through the course of the study. Each study was 24 months in length of time. And you can see there's some robust number of patients enrolled in a very rare disease population for this study. So the study found that revakine gene actually had a greater preservation of easy area over 2 years compared with sham in the treated patients, with almost a 36.2% reduction in photoreceptor loss over that 2-year time period. There was also a functional benefit for these patients with a reduced reduction in reading speed over the course of the study as well, with 68.2% reduction in the reading speed decline that we'd see normally in these patients over a 24-month period. In addition, when you're looking at microperimetry, there was preserved aggregate retinal sensitivity over 2 years compared with sham in these patient populations, with almost a 40% reduction in aggregate retinal sensitivity changes across these 3 studies. So let's play this surgical video, and hopefully this plays. Yes, it does. So importantly, in this surgical procedure, you want to be 3.75 millimeters posterior limbus, 3 millimeters in length of the actual incision with a MVR blade, very closely making sure to inspect the scleral wound to make sure you're through the choroid into the vitreous cavity. Very important to rinse that media off of the implant at the time of the implantation procedure. There's a Prolene suture that's passed through that guide point, as you can see on the top, and you want to confirm that the actual knot, which you place in a 3-1-1 fashion, is actually at the apex of the knot in order to retrieve the implant for future use. Once the implant is confirmed at the apex, then you can actually place it within the vitreous cavity, and then you pass the prolines 90% through the scleral depth on each side of that implant to then, again, tie 3-1-1 at the top of that, that suture. And then the suture edges are then incorporated into the side of the wound, and these are not the closure sutures, so you'll then pass nylons that will encapsulate the rest of the wound and make sure that's watertight, and those will then be rotated into place. The conjunctiva will be closed with both tenons and conjunctiva to the actual limbus with a scleral bite to prevent retraction. These are some of the, I think, important best practices. It sounds very simple, but again, I think with all of our work with PDS and other sort of recent Retisert technologies, it's been actually something that we've been able to appreciate, and it's important to make sure that we don't see this sort of change in our patients from that perspective. So just to conclude this talk, revakinolone has been conferred for both anatomical and visual benefits in these patient populations in these randomized controlled trials. Both phase 2 and phase 3 studies read out positively for both preservation of the anatomy and preservation of visual function in these patient populations. Thank you very much.
Our next speaker, coming from Cleveland, is Dr. Alexandra Rachaskaya, talking about clinical experience with the port delivery system.
Thank you so much, Prithvi, and such an honor to be here with you today. These are my financial disclosures. So port delivery system is the refillable ocular implants for the continuous delivery of customized formulation of ranibizumab. It's surgically implanted and allows for in-clinic refill exchange procedures. It's been approved by FDA for neovascular AMD, diabetic macular edema, and diabetic retinopathy. And I'll share with you today some of the most up-to-date data on these disease states. So when we think about neovascular AMD, we probably have the largest cohort and the longest follow-up to look at the outcomes for these patients. Latter was phase 2 trial, and those patients were then rolled over into the extension trial called Portal. Archway was the pivotal phase 3 trial, which compared the PDS refilled every 24 weeks compared to monthly ranibizumab, and it's met its non-inferiority outcome. Those patients were also then rolled into Portal. So this is some of the newest data looking at the visual outcomes now up to 7 years. And as you can see, when we compare it to baseline to outcomes up to 7 years, the visual acuity was generally maintained. And in fact, over 50% maintained 20/40 vision or better. What about the anatomic outcomes? Well, once again, the graphs looks very similar with maintenance of CST when we look over a period of 7 years. We always get concerned with our patients developing macular atrophy, and this is the data looking at the incidence of new macular atrophy. If you look at the eyes without baseline macular atrophy, the incidence between monthly ranibizumab and PDS at week 96 was very similar. What was interesting, though, if you look now at the macular atrophy progression, looking at mean area, those eyes that didn't have atrophy at baseline and started developing it during the study, there was significantly less atrophy development in PDS, and that was about 4 times that seen in the monthly ranibizumab. Now switching to diabetic macular edema, this is the Pagoda trial where patients were randomized to PDS or monthly ranibizumab, refilled every 24 weeks, and it's also met its primary endpoint of non-inferiority at week 60 to 64, and then patients were eligible to receive the PDS implant if they were in monthly ranibizumab group. And here's the data of visual acuity up to week 112 now, and we can see that the gains that are seen with treatment are maintained, and we do see this expected vision changes right after the surgery. What about looking at non-proliferative diabetic retinopathy? This is Pavilion, and here you have superior efficacy that was shown with PDS refilled every 36 weeks now, and this was compared to clinical monitoring. And once again, patients were then eligible, those who were clinically monitored, to receive PDS. And we see this nice maintenance of the two-step DRSS improvement, which was the primary outcome, in the group that was implanted with PDS up to 100 weeks, and the group that was controlled initially and then was implanted with PDS also shows improvement and maintenance. When we look at the vision-threatening complications and center-involved DME, we can see that in the PDS group, there was very low instances of that. And then in the patients who were switched from controls to PDS, we can see a decreased incidence of these events as well. So I covered the neovascular AMD, DME, and DR, and these are approved treatments. But there's also very exciting research that is ongoing. This is Burgundy phase 1 and 2 trial. And what it does, it utilizes PDS, but also works on administering a therapeutic that would have VEGF-A and Ang2 inhibition. And this is zivabancimig, and we are excited to see what the results of these studies might show. Thank you so much for your attention.
The next talk is going to be given by Charles DeVore on lens-integrated drug delivery emerging concepts. Charles.
All right, well, thanks so much for having me. I have a provisional patent here related to this. Charles DeVore, coming from Bayer's Eye Institute. So this is a little bit earlier stage than what we've been talking about. But one of the things that we've been interested in is using the lens capsule as a drug delivery site. If you look at the lens itself, we do cataract surgery on these patients all the time, and we remove the lens quite safely. And the volume that's available is between 140 to like maybe a little under 200 microliters of space, with an intraocular lens being placed in the center of that. Intraocular lenses themselves with modern technology are quite thin and take very little of that space. And even if you keep the central 5 millimeters clear for an optical axis and trying to put drug delivery in the periphery, there's still quite a large area of potential volume that you could use. For example, in a 45-year-old, the total volume of the lens is about 160 microliters, and the peripheral volume is about 80 microliters. So that's a little bit over the intravitreal injection that we would do. There's also a large precedence of using large implants in the eye. And the left there, that's an intraocular telescope. This is 120 milligrams in air, 60 milligrams in aqueous. And accommodating intraocular lenses have also been used, and they do fill a lot of that volume for mechanisms to try and fill and try and accommodate the mechanisms. This is an accommodating intraocular lens that we had built, which was a fluid-filled, which is 100 milligrams in air, negative 3 milligrams in aqueous because it was filled with a silicone oil, was lighter than the fluid itself. And then there's companies like Power Vision, which have large fluid-filled optics that fill it. So there's a large precedence of being able to use this for devices that can fit inside the eye. People have explored using drug delivery through the intraocular lens, either by soaking, using surface modification, or supercritical impregnation of the lens. But this all involves putting the drug that you want to deliver into the lens itself, and that's right along your optical axis, which you want to keep clear. You want to give good vision to these patients. Spyglass right now from their website has 2 drug pads that sit on the haptics of an intraocular lens, and they deliver bimatoprost, and they're planning to deliver that for about 3 years. This goes through a small surgical incision, is implanted in, and if you look at their pipeline, they talk about delivering other drugs too, not only for glaucoma, but you could imagine steroids for uveitis or postoperative inflammation, NSAIDs, or maybe drugs for AMD as well. So the rationale is that the lens capsule is safe. We do millions of cataract surgeries yearly quite safely. These devices can go in microincisionally. We have a large main wound that we put in, and the devices can collapse or they can be filled after they've been implanted as well. Some of the work that we do is we work on developing a ring that goes outside of the intraocular lens itself for the drug delivery site itself. And this solves the core problem of safety for a medical device that you're trying to implant into the eye. It has a drug reservoir, a refill valve, and then a drug-eluting filter. So this can be filled and refilled in the eye, ideally placed at the time of cataract surgery if it's going to go inside of the lens capsule itself. One of the key questions is, I'm interested in delivering to the posterior segment of the eye, but we know that the aqueous humor is delivered from the ciliary body and comes around and comes out of the trabecular meshwork. So the question is that sort of advection or that fluid flow going to prevent diffusion or not? And if it does, what do you do? Maybe you can open up that posterior capsule. Our early simulations are promising, but I think this needs a little bit more investigation into animal models and then maybe the human model as well. We fabricate using a combination of advanced 3D printers that we have, custom ones at Stanford, as well as with microfabrication techniques as well. We can develop very thin walls so that most of the space itself can be actually used for the drug reservoir itself. And we can get long-term drug release. This is an example of a large molecule, bevacizumab, but other drugs or molecules are capable. And we use biocompatible materials so that they're safe in the eye. This is just an example of an implantation in a pig eye ex vivo using a implanting device, but you can just as easily put it in by itself because it kind of curves into the capsule quite easily. And then for refill, this is sort of a time-lapse refill using a labeled fluid to show that you can refill it after it's been implanted as well. So in summary, I think the lens capsule is an interesting, attractive site for drug delivery due to the large size, history of safe implantation techniques in cataract surgery, and the location between the anterior and posterior segment that can allow you to deliver either to the anterior or the posterior portions of the eye itself. There's several people who are, several different companies that are working on this. Here's a few of my references, and then I'd like to acknowledge your team and funding. Thank you.
Our next speaker is Dr. Nina Barakal from Miami.
Great. Thank you. Thank you for the invitation. Thank you for having me today. My talk. Great. So I'm going to talk to you about cutter speed and surgical efficiency. How high can we go? My disclosures. So we know that we want things to be fast. We want them to be efficient, but we also want them to be safe. So you can go to Steve Charles and listen to him talk. He gave you the MIT explanation of duty cycle and all that, but I am not Steve Charles, so you're going to get the simple explanation of all this. So as you know, we have improved the cutters, and we have made the opening of the cutter closer to the end. We have created a bevel tip to the cutter, and we have also changed the blade of the cutter. So with the single blade cutter, you get the cut rates increase the duty cycle, but as the duty cycle increases, which is how long the port is open, the float rate goes down. So if you have slow flow rates, you're going to have decreased cutting rates, and you're going to have worsening as the gauge goes down. So one of the clever designs that have been created is the dual blade cutter, because it cuts both ways, and you can leave the port open all the time. It's open more than 90% of the time. So you are increasing the efficiency of the cutter. And not only that, but you can go very small in your gauge. And you can see here I'm doing a case with a dual blade cutter of a child with a vitreous hemorrhage in X-linked retinoschisis. And you can see how efficient that is. And this is when I realized how efficient the dual blade cutter is, since I do so many cases in kids that have foreign vitreous. There's a big difference when you use the dual blade cutter. I can be more efficient in removing the vitreous in these kids than when I use the single blade cutter. And not only that, but I can actually go to 27 gauge cutters, and I can efficiently remove the vitreous in kids that are as small as premature babies. So for me, you know, at Bascom Palmer, I never understood why people were still using 23 gauge cutting rates, and I think I was able to go to 25 gauge and 27 gauge because I used a dual blade cutter. And you can see here that if you compare the 10,000 cut rate versus the 20,000 cut rate dual blade cutter, you can see that the flow rates are maintained high, not only in 25 gauge, but in 27 gauge. And experimental models have shown that increased cutting rates decrease tractional forces, so we want to cut fast. But you can also see that why does it cut fast? Because it takes tiny little bites. But we have seen that with tiny little bites, it can also pull vitreous. So what happens when you take little bites is that you're using pulsative flow in the single blade cutters that you are not using in the dual blade. So the dual blade is much more efficient, and it doesn't really pull vitreous since the port is always open, so you have a high duty cycle. And you can see the single blade cutters need increased vacuum to achieve the similar flow rates that we get in the dual cut blades. And you can see the dual blade cutters have shown less pulsative flow than single blade. We don't want pulsative flow because I think that pulls vitreous, especially in eyes that have formed vitreous, like the smaller children, young people, and diabetic eyes, for example. So less pulsative flow results in greater stability with less vitreous and tissue movement. And then we have what's coming out, which is the Unity. Well, it's out, and it's very exciting. You can see that you can do 27-gauge surgery with a dual cutter blade, and you can be very efficient. You can see that piece of nucleus removed with 27-gauge surgery without any issues. So I think this is really changing the future of retina surgery, not only in the instrumentation that we use, but the efficiency and the safety of these eyes. So currently, single blade high-speed cutters are a major advancement over past instrumentation, but innovation doesn't really stop at good enough. It strives for better. I think the dual blade cutters increase efficiency and increase safety. And just like 20-gauge surgery is long gone, I think single blade cutters will soon become a thing of the past. Thank you very much.
These papers are open for questions. Please come up to the microphone. Gaurav, do you want to start?
Yeah, Charles, you presented some nice concepts. So first question, what do you do with eyes that are already pseudophakic, right? You had mentioned about doing this like cataract surgery, and maybe this is another premium IOL procedures that our cataract surgeons would come up with. So I'm curious, what do you do with this?
Yeah, I think that's a great question. One thing that's nice about doing it at the time of cataract surgery is a single surgery. So kind of all of the surgical complications and all of the things that we worry about in implanting a device are sort of taken care of in the sort of same risks of the cataract surgery. Implanting afterwards, we're working on that actually. Putting an implant in the sulcus would be the best solution for that instead of trying to reopen up the bag again.
And the advantage that you have versus impregnating, let's say, a lens or coating it, is in those things you always worry about the drug leaching or the bioavailability of that drug, right? So that's going to be an issue. You don't know how pure that is. This sort of avoids that problem, correct?
Exactly, and it keeps the drug out of the central visual axis too.
Nina, so many of our fellows are becoming lens specialist surgeons. Are you concerned about putting something potentially bulky in a capsule and that dislocating, and then you have this device that now has to get either resuspended or reanimated? What are your thoughts on that?
Well, since I'm a retina surgeon, I actually find it exciting to be able to take that thing out or suture it in some other way to the eye. So I think like any new technology, it will bring challenges, but as we are very creative, we're going to come up with great ways of fixing things like that.
It's going to be new surgery of refixating it.
Refixating it, yeah.
So Nina, just a comment, and I enjoyed your talk, and I think for people who have lived through the era of 600 cutting, and then you go to 8,000 to 10,000 to 16,000, at some point that delta difference doesn't really make a big difference. But I think as we initially saw the TDC and the Even Nexus and then the Alcon, is those things have really made where you almost feel guilty. The vitrectomy goes so fast. We tell the fellows, maybe take a little bit more time so they kind of think we're doing something in here. But it's really amazing that how quickly it happens. And you don't really want somebody if they've never experienced it, it's pretty amazing.
Right. I think that maybe one day we'll have, instead of just one cutter, 2 cutters and a chandelier, and that way we'll be extremely efficient.
So I'm interested in the fact that we can have drug reservoirs and as a way to get drugs into the eye. Charles, you're talking about a drug agnostic type platform, and Alexander, right now we have one drug going into the platform you discussed. Where are we in terms of what we all are talking about, which is multimodal treatments, having a different timing of when drugs get in, and what are the challenges other than just figuring out the right drugs, but say putting 2 drugs into a PDS or 2 drugs into the lens capsule?
Yeah, I mean, that's a great question. We haven't explored putting more than one drug in. I think theoretically it would be possible. They'd have to have a similar, if you're going to deliver from the same side, they'd have to have a similar sort of molecular characteristics, or you'd have to formulate them carefully, but I think that's a very interesting point in general.
I think when it comes to PDS, right, we have ranibizumab that's approved. It's interesting because I believe if you participate in the Burgundy trial and you want to put, the patient doesn't want to participate, you could use it for ranibizumab, so you can switch. But obviously, as Charles mentioned, you can't, the dual inhibition is not faricimab molecule. It was specifically designed to be compatible. So I think there's just a lot that needs to go into design and making sure that you get the PK and everything that works.
Alexander, just a philosophical question. So now we've had PDS for all these years, and again, well-done trials, well-designed device. They had the recall, the company did the right thing, made it correct. So despite all of this, right, the use of the device is quite small, right? And is it just because of the time we live in that we have other agents, longer acting agents, and now it may be a 6-month agent, right? So I'm just curious, because the use of the device is despite all of these great presentations, well done things by the company, it's very low.
So I love philosophy.
Yeah. Well, that's why I'm asking.
But I think it's very multifactorial. I think you mentioned some of the answers, right? It is surgery, right? And as much as we love surgery, we're so used to do injections, and it's easy to do injections. And even if you bring up a surgery with a patient, the conversation is very different than an injection conversation. And then at the same time, we have these new drugs. We have new drugs that are approved. We have new drugs coming to, hopefully come into the market. So there's so many options, and they're much more longer acting. So it's not like we're looking at the patients now that we're injecting every month. So I think that my hope for PDS is that all this work and bringing something new and innovative surgically is something that can be a platform that's built upon. And now that we know that PDS is much safer, as you alluded to, than when it was initially studied, that we can use it to deliver other therapeutics. I think that's probably where it's going to go, and not quite with ranibizumab as we have it right now.
So Rishi had to step out, but I have a feeling that the next most common diagnosis that we're all going to learn about is MACTEL type 2. I think that it's probably many of us don't even see it in our patients, and suddenly it's going to be overdiagnosed. This is a novel technology. It's expensive. It probably sets the bar for any other type of gene therapy to some degree. I don't think it's going to be easily accessible in every surgery center around there. Do you think this is going to be something that's, you'll have to then gravitate to centers that can stock it and keep it and have a backup? There was a great podcast on this recently. How do you incorporate these types of newer therapies that do have a cost into your practice?
I think that Luxturna would be like one of those, right? Luxturna started at academic centers throughout the country, and there's a limited number of patients that have RPE 65 that require the treatment or need the treatment. So I think that shows you that it had to start at a place like that. When you tell a company that the treatment for 2 eyes is going to cost $850,000, so yeah.
And I think, really, again, from maybe the company's perspective, it doesn't stop at MACTEL, right? MACTEL was a way to get this type of product in. It's going to be for other diseases going forward. I think the market will play itself out, because I agree that to get this approved through UHC or anybody, that's a big ask for people who are 2050, 2040, which is different than Luxturna, where you have, that's a different disease. And these are people who are not even sure if they want surgery. Right, so it's a very different ask, and I would hope they have other things in the pipeline.
I think the other thing, though, that we might become more comfortable with is, I hesitate sometimes to initiate anti-complement therapy because of trying to prove the benefit to the patient up front. Here we are taking younger patients that have, again, a disease, we know the natural history. We're intervening a little earlier because it's, we know that that's the benefit down their lifespan. I wonder if that's going to change how we have conversations about complement therapy or other preventative therapies.
I think you're right. I think there's so much kind of coming along those lines in terms of preventative therapies that's really changing the mindset. We're so used to, in retina, to be reactive, right? And so it's going to be interesting how these technologies might change how we practice.
And I think one thing that's interesting about that technology is that it is a procedure, but it's sort of, you can think of it almost as a one-and-done procedure. You would hope that once it's in, you're not doing repeated injections. Like when I talk to someone about using a complement inhibitor, there's the discussion of coming back every month or every 2 months, and then the possibility of converting to wet macular degeneration, where this is something where you can kind of address some of the downsides of it up front with the patient.
I think I would always be very careful about using one and done in retina. From history, of all the retina things, there's almost a never one and done, because there's a paper 5 years after that we have to, sorry, you got to repeat it. So I think we got to be careful. There's never one and done.
I think that's fair.
Except we are done with this session. Thank you very much to some great speakers. Thank you.
All the speakers for session 4, please join us in the podium.
Dr. Ratchis.
Hey. Good job. Doing great. How are you doing? I'd like to invite our friend Arshad Kanani to come up to the podium. He'll be telling us how we'll be stopping injecting and using eye drops going forward.
Thank you, Kwan, Prithvi, Diana, Steve, for inviting me again to this prestigious meeting. My goal is to cover eye drops for diabetic macular edema because they're the most advanced. Here are my disclosures. So why do we need anything else compared to what we have? We have great injections. They work really, really well. Well, the reason is diabetic patient population is growing globally. We have a high treatment burden, and many of these patients don't get treatment early enough, and the diagnosis is delayed with the current available options. We have real-world data showing that almost 50% of patients receiving anti-VEGF therapy within 28 days, so just within 28 days of initial diagnosis, receive 3 or less injections in the first year of treatment. So we are under-treating way more than we think we are. When you look at discontinuation rate, this is a great paper from Sophie and colleagues. They showed that from 24 to 60 months after treatment initiation, 30% were discontinued. And this is all the curves for 4 weeks, 8 weeks, 12 weeks. So no matter what the interval is, patients are discontinuing. And this is a great work from Kwan and team that presented at URetina about the impact. If we have something that can reduce the injection burden, the impact will be less anxiety, less time off from work, reduced need for support from family and neighbors. And then for our clinic, reduction of insurance burden, getting authorization, and then allow us to treat new patients. So with that background, let's look at eye drops. So OCS-01 is a novel eye drop. It's a first-in-class, non-invasive option to current standard of care. There's nothing else in late stage. We have a lot of available treatments. We have gene therapy and TKI, sport delivery system, a lot of exciting things. For a non-invasive, we only have OCS-01. What is OCS-01? It's a steroid eye drop. Uses dexamethasone, 15 milligram per ml, using an OptiReach formulation, which allows the nanoparticles to go to the back of the eye and treat DME. This was studied in the stage 1 phase 3 DIAMOND study where OCS was evaluated compared to placebo eye drops in patients with diabetic macular edema. Patients received 6 times a day drops for 6 weeks, followed by 3 times a day for another 6 weeks. And the primary endpoint, obviously the study was 12 weeks, but the primary endpoint was at 6 weeks. So what did we find? We found that OCS-01 had rapid and significant improvement in BCVA compared to vehicle, which was the placebo eye drops, at week 6 following the induction phase, which was sustained following the maintenance phase. And look at those p-values, they're very significant, and there's no, the error bars are not crossing. So this is actually real in terms of vision gains. Now look at patients who are 3-line gainers. Significant difference here again, starts early, and then we can maintain that after the initiation with 6 times a day. So really showing that the drop is actually working very well. Well, we want to correlate function to structure. So when you look at OCT, you see this rapid improvement in OCT within the 2 weeks of starting the eye drop. And you can compare that to the placebo where you are seeing a steady OCT. And you're able to maintain that with 3 times a day dosing. Obviously, safety is a priority. It's a steroid drop, so we know what to expect. We saw, 20-30% range of increased pressure in the patients, but this was well controlled with the treatment. We did not see any cataracts, given that it's a short study, so we will learn more about OCS-01. The pivotal program, the DIAMOND 1 and DIAMOND 2 studies, are fully enrolled, and we expect data sometime in the second half or so of next year. Now, IOP, we also wanted to look at how high the IOP was 6 times a day versus 3 times a day, and you see that this was very similar across the loading and maintenance phase. So these are my conclusions. Whether you agree or not, anti-VEGF have revolutionized what we do for our patients with DME, but the treatment burden leads to suboptimal outcomes and poor real-world outcomes. Of course, the second-generation agents are helping with that, but we are not there yet. Based on the data from stage 1, OCS holds the potential to address unmet need for having a topical, novel, non-invasive option for patients with DME. And OCS can be used early enough where we are not treating those patients with mild DME because injection, the risk and benefits don't make sense. And OCS can be used in combination with intravitreal injections where we know that DME is a multifactorial disease to control the inflammatory cytokines. So no, don't be worried. Eye drops are not going to replace injections, but they will help with early intervention and decreasing treatment burden. And my hope is that we will improve the outcomes for our patients. Thank you very much.
Thank you very much, Arshad. Certainly welcome everyone to session 4 here. And next to me is Dr. Ted Lang from the Bio Institute, who's moderating with me. Thank you, Arshad, for leading us with this session on novel treatment. Our next speaker is come from Moorfield Eye Hospital in London, Professor Hari Prasad, and this aspect, Hari Prasad. And she would be discussing the concept of reversing retinal ischemia, whether it's a myth or the truth. So, Soba, welcome.
Thank you very much, Kwan, and thank you for the invitation. So my topic today is reperfusing ischemic retina, is a myth or reality. So these are my disclosures. So first of all of us know that DRSS, as DRSS score increases, it's usually associated with increasing retinal non-perfusion. And we also know that a substantial proportion of patients treated with anti-VEGF agents improve 2 or more step DRSS score with treatment. However, studies like the Clarity trial have shown us that despite the improvement in DRSS, there are no changes in retinal non-perfusion. So there's a dissociation between DRSS and retinal non-perfusion, hence the need for other biomarkers to measure retinal non-perfusion. So this is Justice Eller's work that looked at a composite of ischemic index, microaneurysm count, and leakage index. Together, the three of them showed that each of them increases with severity of diabetic retinopathy. And hence, they have developed an automated machine learning platform for angiographic evidence and extraction of these three features. And you can see here that they definitely increase with severity of diabetic retinopathy. But I'd like you to note that in the PDRIs, you can see a wide inter-individual variation. This has been trialed in the RUBY trial where these endpoints, the composite of three endpoints, have been used. And it shows that the total microaneurysm count decreased, the leakage index decreased, and the ischemic area improved at the macula and posterior pole. So this shows us that this is really a reality and not a myth. This was substantiated by the PER-001 trial from Perfuse Therapeutics that looked at long-acting endothelin antagonist for the treatment of retinal ischemia. And there again, they proved that both macula and posterior pole retinal non-perfusion index improved. So anti-SEMA3A is one of the new drugs that are being developed by Boehringer Ingelheim. And this drug is SEMA3A is an axon guidance cue, and it prevents retinal reperfusion. So anti-SEMA3A hopefully will reperfuse non-perfused retina, and they are running the CRIMSON trial looking at the improvement of perfusion with anti-SEMA3A. And I'm glad that they are using multiple clinical endpoints because we at present do not know which of these endpoints will be good. So for color photograph, they're using DRSS, predominantly peripheral lesions and neovascularizations. And for angiography, they're looking at both non-perfusion area as well as index, and then foveal avascular zone and its parameters. The one challenge we have is the change in OCTA features over 12 months is very slow, and therefore, although we run first-in-man trials or early phase trials, we do need longer trials to show an effect on diabetic or any ischemia. We also do not consider the neuronal changes as a result of ischemia in any of these endpoints. However, I do still feel that reperfusion of retinal ischemia is coming out soon, and stem cell-based treatment is another option that we think will be very useful in this field. And you can see here several future therapies targeting retinal ischemia, and so I believe that diabetic ischemia reperfusion is indeed a reality and not a myth. Thank you.
Wonderful talk. Next up will be Sumit Sharma talking about IL-6 targeting in retinal diseases.
Thank you, and thank you for the invitation. My financial disclosures are as listed. We know that IL-6 plays a key role in macular edema, and dysregulated IL-6 secretion leads to recruitment of inflammatory cells, breakdown of the blood-retinal barrier, vascular leakage, and the formation of macular edema. So targeting IL-6 is a plausible therapy for ocular conditions that have an inflammatory component. Vamikibart is the first molecule that I'm going to talk about. It's an anti-IL-6 monoclonal antibody engineered for intravitreal use. And in the phase 1 dovetail study, 3 different doses were studied with 3 injections, so all patients were treated. And what we saw is an increase in the best-corrected visual acuity from baseline through week 12, which is where the off-treatment period started, and that was maintained through week 36. And the CST change showed a dose response, with the lowest dose not working as well as the 2 higher doses. When we look at fluid in the center of the fovea, so in the very foveal center point only, we see that 85% of eyes overall have resolution of fluid after 3 injections for intraretinal fluid and 100% for subretinal fluid. But there's more to it than that. And when we know that in inflammatory retinal diseases, that while IL-6 plays a role, VEGF probably plays a role too. And we haven't seen VEGF monotherapy work well in inflammatory macular edema, but a combination approach might make sense in inflammatory macular edema. In DME, it's the flip story. We know that anti-VEGF works well in a portion of our patients, but 2/3 still have active DME after anti-VEGF loading, and that when you give steroids in combination with anti-VEGF, you get better disease control. And so there is an association of high IL-6 levels in DME, and so targeting a combination of VEGF and anti-IL-6 may make sense. In the phase 2 Bardena study, the vamikibart, so anti-IL-6 plus ranibizumab combined showed superior efficacy in DME in 44% of patients, showing a gain of 3 lines compared to 28% with ranibizumab alone. So this led to accelerated development of a Dutafab, which is VEGF and anti-IL-6 Dutafab that Roche is developing, and the phase 1 trial is ongoing for that. KSI-101, on the other hand, is in trials already and is a anti-IL-6 and VEGF-TREP combination antibody that blocks both VEGF and anti-IL-6. And in the phase 1b APEX study, 3 different doses were looked at in patients with a new endpoint, or with a new entity, which is macular edema secondary to inflammation, really anything other than DME or RVO that may be causing inflammatory macular edema. And we see an increase in visual acuity with each injection, and a decrease in OCT CST over time. And most interestingly, every single patient in the study after 3 injections had complete resolution of both intraretinal fluid and subretinal fluid by week 12. And it's pretty dramatic responses. This is after a single dose, and we're seeing a pretty dramatic response across patients, with 80% at the 1 month time point having no fluid remaining, and again 100% at 3 months. In DME, we see a similar effect. We see a significant gain in visual acuity with a decrease in CST overall. And so KSI-101 is this combination molecule. Switching gears, this is new data that was just announced this week, looking at one of the long-acting therapies, so vorolanib, or EYP-1901, which is being looked at in both AMD and DME. New data this week showed that there may be a multi-MOA functionality because there is inhibition of the JAK-STAT pathway, and the JAK-STAT pathway leads to inhibition of IL-6. And so with vorolanib in DME, we saw a greater effect on both best-corrected visual acuity and CST compared to aflibercept. And when we overlay some of these results compared to the Bardena study, we actually see that the 2 injections, so 1 dose of vorolanib and 1 dose of aflibercept at the very beginning, achieved a similar result compared to what we saw in Bardenas with vamikibart plus ranibizumab. Now, these are different studies, different populations, so you can't quite make cross-study comparisons, but it is interesting data, and it leads to some thoughts that you may see more of an effect in DME with vorolanib. Finally, the last molecule I'm going to talk about is SCN-8143. This is in preclinical studies. This is a trifunctional antibody, meaning that it inhibits both VEGF and IL-6, but it also has Wnt agonism in the form of Frizzled-4 and LRP5 binding. And kind of dovetailing from what was said earlier in terms of retinal revascularization, in an animal model, we actually see an interesting amount of retinal revascularization with SCN-8143 and a reduction in neovascularization. And so this will be entering phase 1 study soon, and I think it gives us another potential pathway for controlling macular edema. So while anti-IL-6 is interesting, there's multiple molecules in development that have multiple targets, and the vamikibart phase 3 data will be read out tomorrow at Subday, so exciting to see the results there. Thank you.
Thank you so much. So next from our state of Florida here, Dr. Christine Kay, the leader in IRD, will give us an updates and advances in therapy. Christine, welcome.
Thank you so much, and thank you for having me to this wonderful course. Again, I'm Christine Kay. I live an hour and a half away in Gainesville, Florida. All right, these are my financial disclosures. I'm going to do my best to give a current update on 5 trials. We're going to go through very quickly, so just highlight. So we're going to talk about 4 gene replacement trials for augmentin for recessive disease, and 1 gene agnostic trial with optogenetics program. LCA1 is our first disease to discuss, involving mutations in the Gucci2D gene. This comprises 20% of LCA. Result is a very profound early vision loss with relatively preserved retinal anatomy. So importantly, in these patients, the retinal structure is relatively intact, making this a good target for gene therapy. ATS-101 utilizes an AAV5 capsid with human rhodopsin kinase promoter targeting photoreceptors via subretinal injection. This is the now completed phase 1/2 clinical design, which has been published in the Lancet. It's a typical Part A, Part B dose escalation, dose expansion. The secondary endpoints of interest are BCVA, FST, and multi multi-luminance mobility. Ocular inflammation was mild and infrequent and reversible with steroid treatments. There were no drug-related SAEs. The high-dose cohort showed improvements that were in the 20 decibel range in FST, and FST in multi-luminance mobility test, which is the maze, showed correlation. Visual acuity and BCVA also improved. On to number 2, LCA5, another LCA. This is utilizing OPX GX AAV5 vector, delivering LCA5 gene directed to photoreceptor cells, again via subretinal injection. This is a recently completed 3 adult patients and 3 pediatric patients results. 5 of the 6 patients had improvement in their visual acuity. FST improvements were durable out to 18 months in the adult cohort, as shown here, with significant improvements in the 20+ decibel range, as well as in the pediatric cohort FST improvements. So meaningful improvements in visual acuity in 5 out of 6 patients. A virtual mobility maze showed improvements in subjects. FST showed clinically significant improvement in 5 out of 6 patients, and safety was well tolerated. X-linked RP affects primarily young males, very aggressive disease, 1 out of 25,000 prevalence. This is the phase 2 DAWN study, which treated fellow eyes of previously treated patients. Ocular TAEs were generally non-serious and mild or moderate. LLVA was an endpoint of interest here, showing significant improvements, and this is the responder data. Microperimetry also showed improvements, and this is a couple of case reports of when patients had treatment first in one eye and then in the other eye with decibel improvements as shown. Data is promising, particularly for LLVA. X-linked retinoschisis shows an OCT here of splitting of the layers of the fovea. Patients lose vision, often to 2200 over time. This is the ATSN 201 administered via subretinal injection, avoiding foveal detachment. Key endpoints were structure, of course, the OCT. Microperimetry is the key secondary endpoint of interest. No DLTs, no instances of macular hole formation. So 7 out of 9 patients had closure of foveal schisis, as shown. Importantly, the untreated eyes did not show foveal schisis closure, and these eyes that had structural improvements had correlating MP improvements, and the untreated eyes did not, as shown here. BCVA was generally improved post-treatment. LLVA results are aligned with other measures of visual function. Here we go through LLVA, and this trial is currently enrolling Part B in a dose expansion and a randomized control portion of the trial. Lastly, multi-characteristic OpCenter MCO platform offers the ability to restore vision. This is now transferring to gene agnostic, targeting patients with low vision or end-stage retinitis pigmentosa, and also programs in Stargardt disease. I'll just discuss the RP data quickly today. Bipolar cells are a target which can be optimized to become sensitive to light with this MCO transgene, which is a proprietary AAV2. Importantly, unlike the previous 4 trials we discussed, via intravitreal injection for this program. And again, the bipolar cells are targeted, allowing potential improvement in vision in patients with loss of vision and end-stage RP. Importantly, to differentiate from other optogenetics programs, goggles are not utilized in the RP program. The RESTORE phase 2b/3 trial, the primary endpoint was met in patients with RP with severe vision loss, which was a 0.3 log MAR change, which is equivalent of 3 lines of vision of ETDRS. The optogenetic platform improves visions in patients with advanced RP or other retinal degenerations in a disease and certainly gene agnostic mechanism by sensitizing bipolar cells to light. It achieved its primary and secondary endpoints at week 52 and 76 respectively. Thank you very much. 10 seconds to spare.
Jack review or? Oh, yeah. Next up is Syed Shah, talking about modifier gene therapy.
All right. Thank you so much for inviting me to give a talk here. I'm going to talk about modifier gene therapy, and my disclosures are listed over here. As we have noted from all the talks before, that diseases are complex, and to target them is even more complex. Take, for example, geographic atrophy. You have multiple factors which play a role in progression of the disease. Now, we have tried to overcome the complement system, but there are a lot more of them in there where the first one came from. So we cannot target all of them together. And in summary, to say that they have Elvin oxidation, they have dwarfish inflammation, and human genetics, they need one ring to rule them all. And that one ring is what we're going to talk about today, the RORA gene. So the RORA gene is a modified gene therapy platform which not only fights the lipid metabolism in the retina, but it also deals with the oxidative stress caused by the ELVs and also the inflammation caused by the dwarfs. And it also deals with the anti-complement as well. So this one gene can potentially rule all of these pathways in geographic atrophy. And now when the rubber meets the road, the OCU410 RORA phase 1 Armada trial for treatment of geographic atrophy showed that there were no serious adverse event or adverse event noted. The mean change in LLVA, it was stable in the patients treated as opposed to 10 letter loss in patients who were the same eye, the fellow eye, untreated eye. As well as GA lesion size, the reduction was 23% slower rate of growth in the treated eyes as compared to the fellow untreated eye. And the phase 2 trial, the phase 2 portion of the Armada trial, the 6-month preliminary interim analysis. Now keep in mind, these were comparators were actually randomized patients, not the fellow eye itself. And the GA lesion size showed a 27% reduced rate of growth when compared to the control eyes, which were randomized but not treated. And when compared to the existing data for complement inhibition, there was almost twice as much reduction in the rate of growth in the treated eyes. And then the same thing for Stargardt disease. The Guardian trial also showed that mean change in vision was significant in the treated eyes as compared to the fellow eye, which was not treated, as well as GA lesion size showed a 48% reduction in growth in the treated eyes when compared to the untreated eyes at 12 months. Now, let's shift some gears to retinitis pigmentosa. I know the ring analogy wasn't very funny for most people, so we tried to change that over here. Also, I see a lot of Gen Z over here. So as you can see, this is an RP. There's so many genes, over 100 genes and counting are responsible for the disease here. And then you can see a plethora of trials. You'll see in any dystrophy that Dr. K very well summarized. There's so many trials and so many targets. You can't just target all of them. So that's when you need, in the multiverse of madness, or shall I say multiple genes of madness, you need the Dr. Strange, the IF Agamotto, which is OCU400, a modified gene therapy platform, NR2E3. Now, NR2E3 not only is involved in photoreceptor development, but phototransduction, metabolism, cone development, and also helps in inflammation and survival. So the photoreceptor survival is reached when you treat with this, and of course, the restoration of retinal cell homeostasis. The phase 1 and 2 RP trial, as well as the phase 3 Limelight trial, is ongoing. And the results from the phase 1 trial showed that the patients with low luminance vision in the treated eyes had an improvement as opposed to the loss, both at 1 year and at 2 years sustained increase in vision, as well as in the RHO subgroup, only RHO patients analyzed. The same thing for mobility test completion. The time was decreased. They could do it in a quicker time. And the visual field preservation was noted in 75% of the patients. To summarize, that modified gene therapy platform for RORA has proven safe and effective in the early Armada and Guardian trials and their ongoing phase 2 Armada trial, as well as the Guardian 3 trial. Same thing for the modified gene therapy NR2E3, in which OCU400 phase 1-2 RP trial has shown promising results, and the Limelight trial is ongoing, and also FDA-approved expanded access program for patients that do not have any other treatment available to them. Thank you.
This session brings to you the latest discovery and work in therapy. Our next speaker will bring Dr. Soba Silva Prasad back again from Morphew, who will discuss with you now the latest approach. Would be gene therapy for geographic atrophy. Soba?
Thank you. So I know a previous speaker spoke about a number of pathways for geographic atrophy. I'm going to concentrate on the complement dysregulation being a key driver of the pathology in geographic atrophy. And you can see here that for complement activity, it is regulated by CFI. And for CFI to work, it requires a cofactor to degrade the complement protein C3b and 4b. So complement receptor 1 is a potent cofactor. And the complement therapeutics are developing a truncated version of the CR1 called mini CR1 that retains the full cofactor activity, and it is delivered as a gene therapy. The aim is using RPE cell as a biofactory for this mini CR1 to produce sustained, durable complement modulation. So the CTX001, that's the therapy, it encodes the mini CR1 by which it degrades C3b, C4b, and all downstream products, both in the classical and alternate pathways. Mini CR1 it has also got the potential to differentiate to penetrate different ocular compartments, and ex vivo porcine and human Bruch's membrane studies here shows that how it can penetrate the Bruch's membrane in Bruch's membrane. So mini CR1 is also a potent MAC inhibitor, and in sodium iodate models, mini CR1 was also shown to demonstrate functional benefits by showing improvement in electrophysiology. NHP GLP tox studies was done in 48 NHPs and in receiving bilateral CTX001 administration with no steroid prophylaxis, but it showed a safety profile, good safety profile with mild to moderate cases of inflammation which responded to topical steroid treatment. It also showed good target engagement with vitreous levels of mini CR1 at week 4 and week 13, showing minimum target exposure levels above the minimum target levels desired. The target engagement was also confirmed with increased level of C3b breakdown products. They are now embarking on a phase 1-2 study called the OptiGain. It's a dose escalation study as well as an expansion study that will evaluate the subretinal gene therapy of CTX001 in 75 patients, with a primary endpoint being EZ attenuation. Preceding this, they will run the pre-gain study, which is a 6-month non-interventional run-in study, so that they will get pre- and post-intervention comparisons as well. The recruitment will be supported by a 235 natural history study called the IGAIN study, which started in 2003, which was used to validate the EZ endpoint. So the 12-month study data will be available hopefully by second quarter of 2028. So in summary, CTX001 is a highly differentiated complement modulator with unique properties of significant potential to effectively treat geographic atrophy. It's an AAV gene therapy administered retinally, and it can cross the Bruch's membrane and maintain activity, enabling complement modulation within retina and choroid. Thank you very much.
Our final talk will be from Jia Horong Hung on JAK inhibition in uveitic diseases.
Thank you for the introduction. On behalf of my team member, I'm very honored to present our data regarding JAK inhibitions in uveitic diseases. This is our disclosure. Janus kinase are intracellular tyrosine kinase that will transduce the signal from cell membrane to the nucleus. Those signals can be triggered by multiple pro-inflammatory cytokines, including IL-6, which is, of course, very important in the pathogenesis of uveitis, as demonstrated by Dr. Sharma. Currently, there are JAK inhibitors in the market, but none of them has been approved for non-infectious uveitis. Breptositinib is an oral small molecule TYK2 JAK1 inhibitor. It can reduce the activity of IL-6 and interferon gamma. The phase 2 trial demonstrating the efficacy of breptositinib against the non-infectious uveitis is called NEPTUNE study. In NEPTUNE study, the patients are randomized into a higher dose arm, 45 milligram, and a lower dose arm, 15 milligram, and at baseline, all of them received a short course of the steroid tapering. The primary efficacy endpoint is evaluated at week 24, looking at the treatment failure, and we follow the patient up to 52 weeks. The baseline characteristics are similar between the two arms. Let's look at the treatment failure. At week 24, the primary efficacy endpoint, it shows that the breptositinib shows a reduction of the treatment failure in a dose-dependent manner. The similar results can be seen in week 52. And we all know that the time to treatment failure in the Visual 1 trial leads to the approval of the Humira because it has a longer time to treatment failure. In comparison, in the Neptune study, the breptositinib can extend the time to treatment failure compared to Humira in Visual 1 trial. Regarding the central subfield thickness, the breptositinib 45 milligram associated with a sustained improvement in the CST through the week 52. The light blue line is the 50 milligram, and the dark blue line is the 45 milligram. The safety profile is generally positive. The most common side effects is arthralgia and rash, and also the increased CPK. Notably, there is no death or major adverse side effects. Given the efficacy and the safety of this medication, there is an ongoing phase 3 trial named Clarity. In Clarity, there are two arms. One arm is 45 milligram breptositinib, the other arm is placebo. The beautiful part is that in the period 1, which is a double mask period, if there is a treatment failure, the patient can be crossed over to an open label period 2. Now, we would like to share some case from the Bioscience Institute at Stanford. First case is a 30-year-old female with idiopathic choroidal retinitis. We could see after 6 months in the trial, the hypofluorescent dots on the ICGA improved significantly. The second case is a 39-year-old male with panuveitis and retinal vasculitis. FA demonstrated leakage of the optic disc, macula, and the peripheral vasculature. After 6 months of the treatment, we could see significant improvement of the FA. Furthermore, on the OCT, we could see the improvement of the cystoid macular edema. The third case is the 39-year-old female with birdshot choroidal retinitis. After enrollment, we could see the hypofluorescent dots on the ICGA aggravated at week 12. Therefore, the patient was crossed over to the open label treatment of breptositinib in period 2. And after 4 months of the treatment, we could see there is a significant improvement of the hypofluorescent dots. In summary, in the Neptune study, oral breptositinib for active NIU leads to the reductions of treatment failure and sustained improvement of CST with rapid corticosteroid tapering. These three benefits can actually help us to improve the treatment of NIU. Therefore, we are looking forward to the result of the phase 3 study Clarity. With that, I would like to thank my mentor, Professor Wen, and I would like to thank Dr. Dahlia, who handled all the clinical trial subjects so well, and my wonderful team. And I would like to thank the committee for having me here. Thank you very much.
Okay, we open the session for discussion here. Any question from the audience? Dr. Arshad, since you're still here, let's ask you this question. Arshad, given the data that a topical treatment gives us decrease in thickness and improvement in visual acuity, if OCS-01 were to be approved, what make it not likely the first-line therapy for any patient with diabetic macular edema at a start with? You did say that it's not a replacement, which I fully agree, but given the safety so far, given the route administration, why would anyone not go ahead and use OCS-01 as a first-line therapy for diabetic macular edema?
Kwan, that's a great question. So I think, as I said earlier, disease, absolutely. But we see a lot of patients with DME that also have PDR. We have patients who have history of a steroid response. So we just have to cater it to the patient's need. And we saw the reduction that is very quick. So I think OCS-01 can be started, but there are going to be patients who will have residual edema that will still need anti-VEGF injection.
And I think you raised an excellent point that is for that concept that we're talking here strictly with diabetic macular edema. Dr. Kanani also mentioned, obviously, when there's PDR and other aspects as well, that we definitely need anti-VEGF. But I would think that this is great for our patient because, as a starting point, because some of our patients with 20/25 or even 20/20 vision with fluid there, that would be an excellent option for that aspect from there.
Yeah, no, I agree. I think the question was, it's not replacing the injections, but definitely a first line in a lot of patients, milder disease. And I think, Juan, you have done a lot of work on steroids, right? We have patients who are getting monthly second-generation agents and still have edema. Those patients will really benefit. The other one that we don't talk about too much is patients getting injection every 2 months. Can we add OCS-01, and now they get injections every 4 months? So it's a huge potential.
That is really great. Now, Dr. Ord, in addition to OCS-01 being studied in the diabetic macular edema trial, you are leading a study program looking at OCS-01 for post-surgical macular edema and uveitic macular edema. Do you think there's a role there, Dr. Ord?
Yeah, that's a great question. And now, Dr. Kanani has shown that this medication, it works at the posterior segment of the eyes, and so a lot of patients that we see with uveitic macular edema in controlled patients that may still have macular edema remaining, this may be an excellent option. And currently, we are in phase 3 trial, and we are currently enrolling in these patients. And I think the enrollment is currently, almost ending. So hopefully, we'll have some rollout data coming up in future meetings that we can share about its efficacy in uveitic macular edema and post-surgical macular edema as well.
Sobha, it was really great data you showed about the ability of these agents to improve the ischemia in the imaging. What kind of data or evidence do we have that restoring the flow back to the retina actually helps with the functional, of the eyes?
Yeah, it's a very good question. So we all know that we see several areas of retinal non-perfusion where when you do microperimetry, they show no deficit. And whether we will improve function in these patients remain unclear. But clearly, if you're improving perfusion at a timely manner before the appearance of drill or disorganization of the inner retina, probably there will be a window by which we will be able to improve function. We don't know when and how we do that.
Have people looked at OCT angiography to see which layer of the microvasculature improves earlier or later in these drugs?
Of course, there are lots of small series of reports coming out. But I think we really need trials like the Crimson, large trials that will tell us which layers are involved. And I think that's why their endpoints in various ways will give us a lot more outputs that we need.
Okay, now let's attack the situation with the interleukin-6 and the JAK1. So in general, uveitis has taught always to be behind retina. So this is the first time that I see the retina team follow the uveitis league, because in the uveitis group, we have shown how blocking interleukin-6 has reduced macular edema about a decade ago already. So now it's finally good to set the retina copiers to do on to the retina, which is good. So let's hear from, so Dr. Sumit, you showed the data with interleukin-6 intravitreal reduction in that fluid from there. We also saw that. You also say that when it's combined with anti-VEGF, it seems to be doing better work of this aspect. Do you think that with interleukin-6 intravitreally, would that also help to obviously control macular edema from diabetes, perhaps with anti-VEGF, but for inflammatory disease, do you think along with intravitreal interleukin-6 inhibitor, would that be able to block the overall inflammation of the eye?
So it's a very interesting question, because these studies are enrolling patients with macular edema that may or may not be on immunosuppression already. And so I think uveitis as a whole is a very complex, multiple diseases. And so I think for certain entities, local therapy alone may be enough, but for others, we may need more than that. And we know that local therapy alone is enough in many diseases because corticosteroids work really well, but I don't know if IL-6 alone will cover all of the aspects of inflammation inflammation that we see. So I don't think you can make a blanket statement for all types of uveitis. I think that definitely in certain disease entities, it will be efficacious. I can't tell you a priori which ones those are, so we're going to have to wait and see and learn more. And as we use it more in the real world and see how patients respond beyond just their macular edema, seeing how fluorescein angiography looks, seeing how their ICG looks, we'll get a much better sense of that.
That's very good. I think, and to follow up also that with Gia. So, Gia, Dr. Smith-Sharma showed that the intravitreal injection of anti-IL-6 or anti-IL-6 plus anti-VEGF reduced macular edema nicely. But your study from the JAK inhibitor with just oral therapy only, which is a lot less invasive, provided there's no systemic therapy, you're also able to reduce macular edema significantly as well, quite impressively too. So beyond the ocular inflammation, that aspect from there, as you can see, our retina colleague has used interleukin-6 right now, blocking for diabetic macular edema. Do you think in the future there may be a role, if proptosinib were to get approved for ocular inflammation, would there be a role for it in other conditions like diabetic macular edema?
Certainly, I think that if the disease only involves one eye, and I think local injection is perfect. But if the disease course, like in uveitis, they usually involve both eyes, and the systemic treatment and via the oral pathway, that is a very easy to adopt pathway. It could play an important role in this aspect.
Christine, great review of all the gene therapies that are pending. I was wondering, what your opinion was on how accessible the administration of these therapies will be to, the community once it is out there, and if there's any sort of pearls that you could share in your experience working with these trials.
Okay, and I'm assuming we're talking about the first 4 with the subretinal delivery. So yes, I'm a vitreoretinal surgeon, and I do subretinal clinical trials. Typically in my VR clinic, I don't do a lot of subretinal injections, maybe a handful of TPA, very rarely nowadays with anti-VEGF. So I think subretinal surgery is a bit of a learning curve, and I think there are pearls. It absolutely can be done, and I think that subretinal surgery is something that absolutely can be extrapolated to really all VR surgeons who are fellowship trained, with the understanding that there are certain pearls. I think some of the advantages of some of the newer capsids, for instance, the AAV-SPR capsid in the XLRS trial that I mentioned, that's a spreading capsid, so it actually has the ability to spread past the margin of the bleb. I think it was 7 to 12 millimeters in a non-human primate, allowing smaller blebs that are not foveal detaching. So we're learning surgically how to be safer, how to optimize our techniques. I think that's really critical when I read a paper to read how the subretinal surgery was done. I don't like to just see subretinal surgery was done. I want to see everything about it and how it was done, where it was done, did you detach fovea? And so I think all those things are really critical, but I think we're learning as a field how to optimize subretinal surgery safely. And still it's, right now, the holy grail for treating photoreceptors is still subretinal. Intravitreal certainly for a lot of different solid transgene targets, but for photoreceptors, right now we're still standard of care is subretinal.
Is there any concern about vitreal spillage of the investigational product, or how do you mitigate that if you do see a plume that doesn't go subretinal?
Yes, come to my instructional course on Monday at AAO with Nell Grigori, who's one of my favorite surgeons. She's probably done more cases. Her and Andy Lau are neck and neck, but she has a beautiful PowerPoint showing what to do with vitreous egress. Yes, something definitely egresses when there's different techniques, jet stream and touchdown, and we know that we egress vector. We could do careful vitreous aspiration. You want to wash out. Some trials will use an air fluid exchange at the end to try to decompress that vitreous scaffold, remaining fluid scaffold. But there, certainly multiple learnings I think we've learned over the last decade plus of how to optimize these subretinal techniques, and surgeons are getting better and better at sharing their techniques and having investigator teleconferences and things to share best techniques and best learned practices.
I think I want to add a few things to that. First of all, depending on the disease, it's different. For RP, the treatment pearls you have to keep in mind are different from geographic atrophy or neovascular AMD. Geographic atrophy, neovascular AMD, very forgiving. RP is not so forgiving. And a single bleb versus multiple blebs, that's very critical, especially in RP when the tissue is very limited and you have to deliver it in the macula. Now, foveal detachment, I've seen people up in arms fighting, punching about fovea to be detached or not to be detached. If you ask Rob McLaren, Professor McLaren from Oxford, he has different views on that versus you ask somebody over here. Then you have different views on how the pressure in the eye should be at the time of injection versus what it should be lower or higher at the time of injection. But the key factor is that whenever you deliver, mechanical separation of the fovea is never a good idea. And in geographic atrophy, you want to avoid the edge in case you can form a break over there where if you force off the fluid, vector can actually penetrate that. Rob McLaren showed a very good presentation on the biomechanics of subretinal delivery and how you cannot sometimes control where the bleb is going to go. So those are the few things, and I think Dr. K will talk more about that on Monday, but it's very disease dependent, and there's no reason why it cannot be done in community. In fact, most likely for neovascular AMD and for geographic atrophy, it will be done in community eventually. It is only the retinitis pigmentosa where there may be extra training or extra center, like in Spark Therapeutic LCA, there's special centers where they have to treat it.
So Mahmood, first of all, we enjoyed very much your movie stack, all the beautiful fighting concept there. From what you and Christine mentioned, it is likely that both of you would not vote for suprachoroidal delivery at any type of delivery for gene therapy. Is that correct? You both are very pro subretinal type of injection.
Because there are barriers when you give it suprachoroidal, there are barriers in which the RPE cell underneath it, how would that do to deliver that virus, internalize it, and deliver it to photoreceptors, or if you want to transfect the RPE cells themselves. There are a lot of factors we do not know about suprachoroidal delivery, which unless we know, I have my vote for subretinal delivery. So I'll see what Dr. K has to say.
Yeah, I think it could be in the future. For photoreceptor macular disease right now, we would be limited with some of the devices that we have tried in the field, the Orbit delivery system where you have a cannula that goes back to get under the macula and then has to pop into the subretinal space. So there's some dangers there and some definite learning curves there with that device. But just keep in mind for most of these diseases, we want to treat the macula, maybe not detach the fovea, but we want to treat the macula. The clear side devices and the devices that are pars plana, we're not going to be able to get that macular treatment or foveal treatment that we want for most of our IRD diseases. But I would never say never. I think that we need to continue innovation in that direction and get some suprachoroidal targets somehow with devices back to the macula. I think that there is a future there if we can. Again, we still have to work on the immune system, and the suprachoroidal immune system is much different than the subretinal immune response. So that would be another issue for you to work out for us.
Thank you, Christine. But certainly we currently have two treatments for geographic atrophy, an anti-C3 and anti-C5. Certainly many of us in the audience are using it. One of the concern or one of the burden we have is that the frequent treatment, whether you use it every 4 weeks, 6 weeks, 8 weeks, the patient will need to come back. You just present a very novel technology whereby you use an AAV vector to deliver anti-complement, and hopefully with just probably one injection with this, how confident you are about this process here?
Well, number one, we believe that complement therapy has a role to play in geographic atrophy, and I believe there is, but we don't know whether it is it's universal in all patients, and there may be some phenotypes where it will work and in others it won't. So that's about the concept of complement therapy. And you just had a discussion about subretinal therapy. So I still think it's a viable option given that the uptake of C3 and C5 intravitreal injections seems not that popular. We don't even have access to it in Europe. So I would say we shouldn't discard that option. I think gene therapy is the way forward for such therapies where you need regular injections. Complement therapy, I'm not, we don't know. We can't say it's for all patients, but definitely I think it's an option.
Yeah, and I would add that, technically, not technically only, in real life, we have the phase 2 Armada trial ongoing. The RQ410, the RORA gene platform actually does inhibit complement as well as other inflammatory markers through activation of the RORA pathway. So I think we'll find more about that as the trial progresses through 12 months, and we preliminary data is very promising at 6 months. But again, we have 12 months to come and 24 months as well. So I think that will also tell us that inhibiting multiple inflammatory and oxidative stress pathway along with the lipid pathway is very critical in overall disease. And maybe their uses outside of geographic atrophy where you want to control the inflammation in the eye, and maybe you don't need subretinal in certain uveitic cases where you can deliver elsewhere and you can have the immune system modulated that way.
That's great. Talking about blocking several pathways. So Sumit, let's get back to you. You finished your talk by bringing us some inspiration. Instead of just 2 targets, you now bring it 3 targets. That means you have very not so much confidence in just blocking 2. Now you think of 3 targets, that aspect from there. Do you think that will be complete, or in the future you may end up 4 targets as well too? And so
I think antibody design is getting more and more complicated, and there's always risks the more complicated you make an antibody. I always worry about the other side is what are the risks of multiple targets, and what are the interactions that we're seeing with multiple targets. And there's always a potential for that. Can you get to 4 targets? Probably, because that antibody that I showed you is actually Wnt agonism with 2 targets. And so it's actually 4 targets there already. So yes, you can actually get to 4 targets. Now, I just caution and worry and you have to be very careful in that when you're affecting multiple mechanisms that way, what's actually going on in the eye as you do that.
Great. Gia, certainly, right now, the only biologics approved for uveitis on confirmation and many other indications would be adalimumab and tumor necrosis factor inhibitor. From every set of data you showed so far, propaquetinib to the Neptune, and certainly what we have seen so far, Clarity, have done a lot better. Do you think if propaquetinib were to get approved within a year after the currently phase already finished enrollment, how would you think would it be able to surpass adalimumab as the first-line therapy for uveitis?
Thank you for this question. Based on our data, because as we Stanford actually now are leading the trial, and based on our patients' performance, we have some positive confidence of the efficacy of this therapy, but we are also aware of some of the side effects. But as I have mentioned in my talk, there are no major adverse drug-related AE. So based on our observation, of course, we need to be very neutral to the results because be as scientific as possible. But I think the chance of getting approval could be high. And based on the time to treatment failure comparison, we have to acknowledge that this is not a head-to-head comparison because this is not in the clinical trials. But we compare to a historical time to treatment failure, the brepocitinib actually performs better. And we need to interpret that part very carefully. But this gives us more confidence that this could be a paradigm-changing treatment in the future. Thank you.
Great, and I guess I'll leave the last comment for Dr. Orr here. Dr. Orr, you have listened to all of the present today. What this afternoon session for? What excites you the most, this session for?
Oh, am I giving the conclusive statements here? So I think there are so many different directions that this panel has given, and it just kind of highlights all the innovation that is going into both uveitic diseases and retinal diseases. There are so many different angles that we can look at in these diseases, and give us so much to look forward to and more to think about, I suppose, in the future for next year's INNOVATE Retina to talk about.
Thank you, everyone. Thank you.
So just as a reminder, we have dinner and exhibits outside. Please join us here, and then don't forget about session 5 after that.
Actually, before we leave for the dinner outside, we have a very special session ongoing right now. You know, at INNOVATE Retina, we always have tried to bring up to you the most updated and most exciting thing in us. And in our field, once in a while, we have a new group of colleagues who start up with different type of program in this aspect. Today at this INNOVATE Retina, we will have the launching of U.S. launching of a very brand new company called iSora. And at this moment, we would like to invite Dr. Teresa Heath, who is the founder and CEO of iSora, who will discuss with us. Some of us have known Dr. Teresa Heath. She actually led also the program that have made aflibercept 2 milligram available worldwide outside after the United States has launched that. Since then, she's also launched an outstanding career, including bringing ROCK inhibitor for the treatment of glaucoma. So we're very excited to hear today for the launching of iSora. Teresa, welcome.
Thank you, Kwan. Good evening, everybody. Thank you to the INNOVATE Retina program directors and committee for allowing us to launch IZORA here today in the US. So with that, I'm gonna say a few words and I'd like to show you briefly the video of IZORA. So IZORA is a hub and spoke company focusing in accelerating innovation in ophthalmology. We are basically building a company that's focusing on this with a central hub of assets and technologies and building spoke companies around that. And we are picking assets that are clinic ready or near clinic ready, both in pharmaceuticals and medical device, focusing mostly in pharmaceuticals. And more importantly, we act as a critical enabler. So we provide tailored funding, development plans, all the way to an exit event. And we are merging key geographies starting from Singapore, which we announced last month, and also soon to be announced in Europe. And we are headquartered in the US, in New York. And more importantly, merging academic institutions with industry. So with that, I'll just show you a brief video, and please join us outside to toast with the team for the US launch. So thank you very much. Thank you.
Yeah, go ahead. Do you have a question? Any questions? Okay. Hey, so we're going to get started with session 5, and this is the non-CE portion, so we can say whatever we want, which is actually a lot of fun. And so we're gonna end with a bang here. What I'm going to do, I'm Stephen Smith, I'm one of the co-directors of the meeting. We have a whole bunch of panelists up here, and what I've asked everyone is that they give a 2-minute summary of what they're working on in their company, what they're excited about. And I have a stopwatch here because in the past people have gotten excited and 2 minutes turns into 5, and we're going to try to prevent that from happening, so please don't talk for more than 2 minutes. And then we have some question and answer and just discussion around innovation in the retina space. So why don't we start? Let's go right to left. So Cedric, if you want to start for us and give us an overview of kind of what you're working on, what you're excited about, that'd be great.
Yeah, I'd be happy to. Thank you so much. Thank you for the invite. 2 minutes, wow, that's short. But so, I'm Cedric Francois. I'm the CEO of Apellis, the company that commercializes Syfovre, the first treatment for geographic atrophy. What we are working on at the moment at Apellis is, I would say, primarily not to grow Syfovre through ads, but rather through a deep and better understanding of geographic atrophy. I think that one of the great things that we were able to do in the past couple of years is in our clinical trials. So we had 1,200 patients in phase 3 clinical trials with extension studies that have now data of over a full 5 years of dosing. And in those studies, we also used microperimetry. And to make a long story short, what we have discovered through that work is a method to image across the retina what the sensitivity, the light sensitivity is in patients with geographic atrophy. It's something that we believe will transform the field in the sense that when you look at the decline in function, true function, which is sensitivity across the retina in patients with geographic atrophy, it is really quite dramatic and I believe unrecognized by most retina doctors. 2 important learnings from the work that we did. Number 1 is that GA is not a disease of the border of a lesion. GA is a panretinal disease, and you see that in the dramatic loss of light sensitivity across the retina in these patients. Number 2, best corrected visual acuity does not correlate well with the disease. Many people know that, but it's believed to be related to foveal sparing and kind of the end involvement of the fovea in the disease. But there's also the fixation. So fast progressors who are good at refixating their focal point can have better BCVA outcomes than slow progressors who are poor at refixating. So all of that to tell you that within this disease, we have so much that we have learned, and we have a new imaging tool that will allow physicians to see that. It will also allow us, with the drug, to show the dramatic impact that Syfovre has after as little as 1 injection on improving and slowing down the decline on that sensitivity loss. And we believe that that will make the treatment of geographic atrophy viewed with the importance that it deserves, and new and experimental and existing therapies to be viewed through a different lens.
Great, thanks, Cedric. Lloyd, you're next.
Stephen, thank you very much. Lloyd Clark here. I'm a practicing retina specialist. Recently joined Annexon, helping to head up ophthalmology strategy and innovation. We have a suite of C1q inhibitors that impact neuroinflammation in the brain, body, and eye. We have 3 distinct programs. Obviously, today we're going to talk about our program in geographic atrophy. Very exciting time for us. We've just completed enrollment in our phase 3 clinical trials ahead of schedule, global clinical trial in 14 countries. So we're busy executing on a phase 3 development strategy. We have actually taken a different approach to outcomes in geographic atrophy. One of the key findings from our phase 2 clinical trials was that we demonstrated a significant reduction in events of 15-letter loss, confirmed 15-letter loss. And so we've moved that forward as our primary outcome. And we believe that if we pick the right patients for enrollment, then we have a very good chance at having a significant impact on events of significant vision loss. And so that's our primary outcome. We're really excited to push that forward. It's allowed us to have a well-defined global regulatory path, both in the U.S. as well as in the EMA. We've achieved EMA prime status. So we're really excited where we are right now. We're in the process of executing our phase 3 clinical trial. We look forward to bringing results to the community in the second half of 2026.
All right, thanks so much, Ha.
Hey everyone, my name is Ha Tran. I'm a medical head of biopharma and ophthalmology clinical development at Astellas. For those who are not familiar with Astellas, we are a global pharmaceutical company. And our lead product in ophthalmology is Avastin Captad Pegol, otherwise known as Izervay. We are successfully approved and commercialized in the United States and Australia, and we have conditional approval in Japan. We are very proud of our efficacy and safety profile with both pivotal studies meeting their primary endpoints of reduction in GA growth at 12 months compared to sham. Additionally, we have a differentiated safety profile, which is reflected in our label. So we're very proud of the patient demand and the demand to preserve their photoreceptors and the retina community in playing the role of the protector of vision. At the same time, we have a very robust preclinical pipeline, and we're very excited and challenge ourselves to do more. So we have AAV gene therapy. We are actually a category leader in transplantation with tacrolimus or Prograf on the market. So it's only natural that we are one of the leading companies for allogeneic stem cell transplantation. Our lead program is in phase 1B, phase 2. Ted Lang is actually our lead PI at Stanford. And we're very excited. That's to target patients with advanced GA. We also have a universal donor cell technology targeting inherited retinal diseases. So, what we are most excited about is our commitment to the field of ophthalmology and working with really stakeholders and the ophthalmology community. Thank you.
Great, thanks so much. All right, Malvina, and I think you
Hello.
have a slide, is that correct?
I have one slide.
Okay.
Hopefully everybody will take out the cameras and take a picture of this QR code while I'm explaining why. So for those of you who don't know me, my name is Malvina Edelman. I'm an ophthalmologist by training. I recently retired after 30 years of FDA leadership for about 7 different subspecialties. And since April, I have been a CEO of something called Collaborative Community on Ophthalmic Innovation. It's the only organization in the world that is uniquely positioned to unite every stakeholder in the medical product ecosystem, including all of the regulators, industry, academia, patients, in a pre-competitive space in order to come up with solutions for any problems that any medical product has in reaching patients. There are 2 different aspects of our mission. One is to bring all of the ophthalmic medical products to global markets in the most expeditious manner, and the second is to make oculomics a reality. We have right now we have 17 working groups. It was a very intensive work streams. We also just became a standards organization, so we can write and recommend both national and international standards. I can go on forever, but since I have 30 seconds, what I want to talk about today is what we're doing on October 27th and October 30th. We are revolutionizing how innovation is done in ophthalmology. You know, after 30 years, I've seen everything that can possibly go wrong. And two things that can truly make a difference is if we can come up with a consensus for novel technologies much faster. So October 27th, anybody who is interested in diabetic retinopathy medical product development is invited to join a 2-hour AI remote session where up to 10,000 people from around the globe will be asked 3 questions. And at the end of the session, AI is going to generate consensus of what all the participants around the globe thought about the 3 endpoint sessions that we're going to be asking. Hopefully, this will become a precedent for how AI consensus is done for all of medical science, not just ophthalmology. And on October 30th, we're doing something similar, but with patients. Anybody living with diabetes is invited to join and speak up, and we're going to incorporate their voices for the first time utilizing AI to make this as a foundation of PRO development in real time. I put together 4 PROs in my lifetime. It was 10 to 12 years. This is being done on steroids.
Okay, all right. Thank you so much. Andre, yeah, you went a little bit over. We'll dock you later.
It's okay,
Andre. Go ahead.
My name is Hendrik Scholl. I'm residing in Zurich. Just landed last night. That's the reason why I'm so jet lagged, and I have some notes to stay within 2 minutes. I'm Chief Medical Officer of Belite Bio, adjunct professor at the Medical University of Vienna in Austria, and I'm still seeing patients in Zurich as a retina specialist. What is Belite Bio? It's a clinical stage pharmaceutical drug development company focused on advancing novel therapeutics targeting retinal degenerative eye diseases such as GA and Stargardt disease that have significant unmet medical need. Our lead candidate, tinlarebant, developed from our RBP4 intellectual property portfolio, is a novel oral therapy which is intended to reduce the accumulation of toxic bisretinoids in the eye that cause Stargardt and contribute to GA. What is the most exciting? In GA, we have completed enrollment ahead of schedule in our registration trial called Phoenix, where we enrolled 530 patients worldwide. As presented an hour ago or so by Dr. Michel Michaelidis from the Moorfields Eye Hospital, in our Stargardt registration trial, DRAGON, an independent DSMB performed an interim analysis and felt compelled when analyzing the efficacy and safety results that the data should be submitted for further regulatory review for drug approval. And this needed a small, unmasked group to present the interim data to regulatory agencies, and I belong to that group. And as such, I presented the interim data to the FDA on May 23rd, and in the same month, FDA granted breakthrough therapy designation for tinlarebant for the treatment of Stargardt disease. And 3 weeks ago, exactly 3 weeks ago, we presented the data in person to the Center for Drug Evaluation of China's National Medical Products Administration, NMPA, in Beijing. And yesterday, we published a press release that the China CDA has agreed to accept the new drug application with priority review for tinlarebant for the treatment of Stargardt disease based on the interim analysis from the phase 3 DRAGON trial. I would like to highlight, as a retina specialist being in the field for 2.5 decades, that this is the first time in history that an oral compound can slow neurodegeneration in a retinal disease. What to watch out for? We remain on track to report final top-line data from the phase 3 DRAGON trial in the 4th quarter of this year, and we aim for an NDA submission to the FDA in the first half of next year.
Thanks so much. Teresa.
Thank you. Hi, good evening again, everybody. So just to kind of summarize and to provide elevator pitch on Izora. So we are a global hub and spoke model company accelerating innovation in front of the eye and back of the eye. And so there are three recurring barriers that we see, right, in ophthalmology. One is the fragmented path from discovery to a commercial viable products. You know, scientific, academic institutions, clinician scientists have amazing ideas and the scientific curiosity, but they lack the know-how of translating a particular research into a development to a viable, marketable solution. And a lot of standalone companies, when they're built with one lead program due to funding or due to the need to execute. When that requires a detour, they don't have a pipeline to fall back on. More importantly, you need the capital and the human talent to execute on the plan. So it's very important to create value for all stakeholders. So what we are doing is we are in licensing assets that are near clinic ready or clinic ready. Two of them has been announced. Last month, we announced one for front of the eye ocular surface diseases, a licensing that we did from Singapore Eye Research Institute. Today, we'll announce another licensing, but the first asset, has clinic data, first in human patient data already. The second asset today we announced is a medical device, minimally invasive glaucoma, a surgical device. We're starting clinical trial. And then since we are on the back of the eye summit today, we have 4 potential assets that we are licensing in back of the eye. One is for neuroprotection, neuroenhancement, intravitreal delivery. The other 3 for age-related macular degeneration, conditions that are focusing on fibrosis and beyond what we see today with anti-VEGF, and these are biologics. So there you go.
Great, thanks so much. So what we're going to do, a little question and answer now. We're going to ask people to try to stay to about 30 seconds or so in the response, just so we get a chance to hear from everybody. I want to start, we actually have a lot of GA expertise on this panel. I'm going to start with Cedric and Ha. You're both, we have FDA-approved therapeutics for geographic atrophy for the first time, right? So when I started practicing, I would see GA patients say, I'm sorry, we don't have anything for you at this point. We refer you to low vision. Now we actually have a therapeutic that we can treat patients with, and I use both of your therapeutics in my clinical practice. But I know that there are some colleagues that don't. They say that, hey, the amount of geographic atrophy slowing isn't worth the pain of monthly or bi-monthly shot. What would you say? Let's start with you, Cedric. How do we convince those retina doctors who aren't yet ready to use those therapeutics to actually move forward and offer them to patients?
With imaging and a good understanding of the disease.
And with that imaging, let's just follow up on that a little bit. Because I know you mentioned that in your intro. What specifically, if Mrs. Jones comes into my clinic, is there a specific imaging modality that I should be getting to get me more excited about using these therapeutics?
Yeah, I think that maybe just a brief touch point on how that physician reluctance kind of found its way into our practices. That probably has to do with the fact that a lot of practicing retina physicians, and with the tools that are currently available, they will see a patient, they will look at the last visit, which may be 6 or 12 months ago, unfortunately often kind of eyeball the GA lesion on autofluorescence from then and today, don't see a big difference, then look at the best corrected visual acuity and derive from that analysis that there's not been a lot of change. And any retina doctor will tell you that often the patient will tell you, but my vision is much worse, right? And there's not an understanding of that reality because the tools are not there to qualitatively or quantitatively measure that. That's terrible for the patient because now that we can and we have that tool available, it is actually quite dramatic what happens to these patients. And we owe it to these patients to be seen, to feel seen by the physician as well as by their family members. So I think that's very important, and I truly believe that we're going to see a reframing, kind of a reconsideration of what this disease means for patients. That's step number 1. Step number 2 is once patients are on treatment, and they're on treatment for 6 months, a year, let alone 2 or 3 years, and the patient asks the physician, is this drug working for me? Unfortunately, right now, the answer is, yeah, we have to trust the process. If you have bilateral disease, you may see a difference between the treated and the untreated other eye, but still, there's not that, it's based on trust rather than kind of being able to track it. And that will lead a lot of patients to kind of give up, physicians to not be convincing. We need to fix that, and we can. So I can tell you definitively, knowing the data, that it is real, the data is there. Now it's a matter of bringing that imaging to the retina practice in a way that is very practical.
Great, thanks so much. Ha, what are your thoughts?
Yeah, I thought the CME session was over, but I think industry does play a role here in terms of whether there's anything that we can do in terms of real-world evidence generation to help providers, retina specialists explain things to patients. That would be very helpful. But I completely agree. Like imaging, pictures worth 1,000 words, and I know that. Retina specialists are pressed for time, and that the patient education, does take longer than what you are probably allocated for. So maybe thinking through like how, other members of the clinic can help with that education piece, and anything that we could do to try to help with content. Let us know.
That's great, Lloyd. Let's talk about outcomes a little bit. So you can respond to that as well, but in Nexon, obviously you don't have an approved product yet. So talk to me a little bit more about how you think through outcomes. Obviously you're doing, it's different than the other GA studies, not just looking at GA lesion growth. How are you thinking about that at Nexon?
Well, first of all, I'd certainly agree that we have an explosion in terms of imaging capabilities and imaging analysis capabilities. It really is an incredibly exciting time to be in this space, because we're going to see rapid improvements in the ability to image various biomarkers in the retina and then analyze that in a way that may be predictive of future vision loss, of future disease progression. There's no doubt that that's coming. One observation that I've made in clinical practice for 25 years, though, is that the retina community is not terribly interested to date in treating to biomarkers. And a good example was with anti-VEGF therapy for diabetic retinopathy regression. And the data is very, very strong that you can dramatically reduce the rate of vision-threatening complications by treating sporadic anti-VEGF therapy, but yet the community has not adopted that as a reasonable treatment. So from our view, a meaningful functional outcome is going to be what changes the game in geographic atrophy, and that's really the basis for why we went forward with our functional categorical 15-letter loss endpoint. We recognize that this seems to be a very high bar. We believe that one of the keys to that is to identify the patients that are at particular risk of losing 15 letters during a reasonable period of time and target that as your diseased population. So I'm in firm agreement about the advancements in imaging, and we, as a company, we will take advantage of that as well. I think the community, though, is still in a functional mindset, and so that's what excites us as we push our program forward.
That's great. Thanks so much. Malvina, I'm going to take things in a slightly different direction for you, because I know that you spent a lot of time at the FDA, and obviously you're not there now. As someone who's done biotech as well, drug development not on the device side, I will say that one of the crucial things as an innovator is having collaboration with the regulatory bodies. And so coming up with endpoints, trial designs, responsiveness. What do you think are some of the ways that CDRH, I know that's where you work for, can do better? What are now that you're not there anymore, what are things that you think don't work? What are things you think could be better? How can the regulatory bodies work with us as we try to solve these sorts of challenges for our patients?
And I didn't even ask you to ask me that question. I mean, this is a perfect question. So that is exactly what CCOI does. CCOI started in 2019 with the goal to help FDA get the scientific knowledge from around the globe to make better decisions faster. You know, at FDA, I was very creative in hosting a very, I don't know, probably over 40 different workshops for novel technologies, but it's very time-consuming, very challenging when it's FDA-driven. So in 2019, we came up with a concept where we can just become, FDA can become a participating active member of a collaborative community that can then learn and participate in a global very, very rapid response of generating endpoints and finding solutions to novel therapies. So it has been a growing and very exciting program. As of right now, that is the only collaboration, CCOI is the only collaboration that FDA is participating in. And, I have FDA reps. I was the rep, and then as I was retiring, I was able to nominate excellent people. So for every committees that we're deciding on the endpoints and the standards, I have FDA representatives together with PMDA and HSA, et cetera, and we all come to a joint consensus about the best way forward.
Great. Thanks so much. Hendrik, I am not a believer in general in oral therapeutics, but the markets clearly are a believer in what you guys are doing at Belite Bio. Tell me a little bit more about where we are with your GA program. Again, we're talking a lot about GA here. I know the Stargardt program is advancing, exciting times. Yeah, what's going on in terms of GA?
Stargardt may be more straightforward. It's not gene therapy, but Tinlarebant is extremely specific because it's associated with a RPE expressed RBP4 receptor. So it's almost like gene therapy in that sense. No, but it is oral, and this comes with several advantages. To GA is a different beast. It's clearly multifactorial. I can claim that my group was the first, but maybe Shoba was also the first to show systemic complement activation in AMD. So there are various pathways. But at Bonn University, we had shown together with Frank Holz that abnormal autofluorescence is a driver of the disease. We all know that as treating retinal specialists in GA. And since this is a driver, it's obvious that targeting bisretinoids is a good thing, and with Tinlarebant, you can do that very efficiently. So we feel that, especially in this elderly population, an oral compound would be extremely important. It doesn't have to be the only way to treat these patients. Complement inhibition and targeting bisretinoid composition in the RPE may be complementary, right? So they do not exclude each other. But we feel that if we get to a patient population, even if we have only a modest treatment effect as seen with the complement inhibitors, would be a big plus for the patient community. So I think this is what the market thinks about us, but this is also what I think about us.
Yeah. And what are your thoughts on compliance in general? So I know that as a retina specialist, the field of retina for a while, and he was like trying to get away from intravitreal injections and like, oh, can we come up with an anti-VEGF drop? But the interesting thing is the glaucoma doctors are trying to get rid of drops because patients actually don't take their drops. When you have a therapeutic, like what you're developing that slows the progression of a very slowly progressive disease, do you worry about compliance with patients, like actually taking the medication if they're not seeing better a week after they're taking, they're not feeling anything different?
The good thing is that we have a clear biomarker, namely RBP4, that can be measured in the circulation, so we can very well monitor compliance. Compliance in the Phoenix trial has been excellent so far. In real world, remains to be seen. I mean, patients have a lot to lose, so I would still think they will like that type of therapy better than monthly injections. But when I speak as a retina specialist, the good thing is about with the injection, I do it, I know it's in, and I will repeat it in 4 weeks. So I have it in my control, but patients may give up because they don't want to be injected anymore. So it will need a new standard of care when we have these treatments available. Clearly, patients with oral therapy still need to be seen, need to be imaged, need to be encouraged to take the treatment.
Great. Teresa, we're going to wrap it up here or momentarily. So you've talked about this, the new company that you're launching, and as I'm listening, I guess I'm trying to fully understand exactly what you're doing. Are you actually, it sounds like you're acquiring assets, so you have talent inside your company and you're acquiring assets. How's that different from other, because you talk about this hub and spoke model. Can you just explain a little bit more, like what's different about this than another company that's backed by investors that's going out and buying assets? What sets you apart?
Yeah, the difference is in the central hub. You can, you don't have to duplicate a lot of functions. So for example, a standalone biotech, you have G&A, general administration, finance, legal, regulatory, clean ops, et cetera, you have to duplicate functions. In the central hub with the spoke companies, you can leverage expertise so that you are capital efficient. And that's what we look at when we build a company. You know, drug development is not for the faint of heart, right? I'm sure Cedric will tell you that, how much he had spent to develop, and so is Iveric Bio and Astellas to get there. And so how can we be more efficient, right? Operationally efficient, and also translating research towards a development drug that is viable from a commercial perspective. And if you look at AMD, geographic atrophy as a whole, right? Izervay and Syfovre are the beginning, right? It's just like, it reminds me of Macugen and Lucentis. And there's just more we need to do, but it costs a lot. You need human talent, you need the capital, you need the right approaches, and you talk about durability, treatment burden, patient compliance, adherence. There's just so much variables. So how can you speed up innovation by removing certain variables, being very efficient, and taking innovation to patients?
Great. Thanks so much. So we're just about out of time. I guess in closing, do you have a question?
AI is going to change drug development because a lot of functions, medical, regulatory, and other documentation and stuff, can be taken over. So not only speed-wise, it's going to make things faster, but also it may remove some job functions. So if you can elaborate on both of them, that'd be great. So all of you guys are industry leaders.
So we've got about like 2.5 minutes left. So who wants it?
So AI will not replace us as retinal specialists. Patients will still like to be seen, right? But we can utilize AI, for example, for segmenting retinal images, and that is a tool that we're already using, and it will be a great tool, right? Press a button and show your GA patient, that's the lesion last time, that's the lesion today, without outlining it or do a on fast ellipsoid zone, what have you image, it will all be automatic. That will be a great help.
Yeah.
Yeah. Yeah, I know what he's asking.
And then Lloyd, I think you're going to.
No, I was just to Cedric's point. I think it's going to make identifying patients for clinical trials much easier, much more efficient. I think you're going to be able to run development programs much more quickly. I think with AI coupled with imaging techniques, we're going to be able to develop drugs much more quickly. Aside from all the administrative tasks from a clinical perspective, I think it's going to develop tremendous efficiencies.
And then, yeah, go on briefly.
Yes, so, on the international level, IMDRF has actually starting to put together the documents, and FDA has a number of guidances that talk about how to use AI to help develop drugs, which is what I think the question was about. So this went from future to now. There's actually guidance, it's being done, it's moving very fast, but again, that is only to help everybody on the stage to get to the finish line faster and to expedite things, not to replace people.
Great.
Yeah, briefly, I just want to state that, at Astellas, we're already utilizing AI from drug discovery process to designing our target product profile and our clinical development plans. But the real key is to keep the human in the loop, and it does not replace any of your expertise in this room. So, but it does speed things up.
Yeah, there certainly is going to be change. What it's going to look like in the future, obviously no one knows. But I wanted to say thanks to everyone on this panel, and special thanks to the innovators and those bringing new drugs forward. Again, it's such a privilege to have therapeutics for my GA patients now. And as has been alluded to on this panel, it is a long and painful journey to get a drug across the finish line. And unless you've done it, you really don't have any understanding of the amount of work that goes into that. And we need industry, we need clinicians, we need regulatory experts, right? Everyone working in concert together. And so thanks. And on that note, thanks so much to our sponsors. Thanks to all the faculty for being here. There's going to be a QR code that you can scan to get CME credit. You also get an email for those of you that are interested in CME credit for this event. We will be doing this again next year. So put a bookmark in your calendar for 2026. I don't know when or where, but it's going to be a lot of fun. I hope everyone has a great evening. And again, thanks so much for being here.